All right, everybody, welcome. Welcome to today's course. I know that several folks are still getting breakfast, which is fine. You're welcome to bring food in here as well. We're really excited that you're all here. I know it's a lot to ask, oftentimes to spend a Saturday here on campus, but really appreciate everybody being here. I think it's going to be a really fun day. This is the 11th annual course for Rocky Mountain Highlights in GI and Hepatology. So first, I guess we'll start just by introductions. We have all the course directors up here. My name is Avash Kalra. I'm one of the transplant hepatologists here at the University of Colorado. I did all my medical training here and I've been on faculty here since 2021 in our section of hepatology. And this is my second year as a course director. So thanks again for being here.
Good morning, everyone. I'm Kelly DeLay. I'm one of the esophagus doctors here, also on faculty with Avash. And we're excited to have you. Thank you so much for coming.
My name is Debbie Chen. I'm also faculty here for general GI as well as IBD. Thanks for having us here, and also been faculty since 2021.
All right, so we'll go through just some introduction points before we get started with our first talk. By the way, Kelly, you and I started fellowship together about eight years ago, almost to the day. So look at us now. Thanks to our course organizers. Really appreciate the help that these three individuals have given us and also all of you in supporting this conference. So Matthew McLean and Christy Click are both here today. Thank you both for helping us put this course together. Lindsay Carter as well. She's not here today because she is about to give birth to a baby like any second or something along those lines. So, but thank you to Lindsay as well. Like I said, this is our 11th annual conference. We do have some social media mentions here. So basically you can use this hashtag RMH2024 if you use X or Twitter. And also it would encourage you to follow the official CU Gastroenterology and Hepatology account. So you can see that listed there on the site as well. So the course format today, there are 5 sessions. It includes panel discussions and Q&As afterwards. Attendees you are all encouraged to ask questions during the Q&A via poll everywhere or the microphone. We'll kind of go over that a little bit later as the talks get started. Also want to thank our sponsors, and we'll thank them all individually here in a moment. But we do have, as I'm sure you saw as you walked in, an exhibit hall surrounding the food outside. So please talk with our sponsors. They really are a key component to this course. They're a reason that the registration is free for all of us. And we do have a raffle later today at the end of the course, during which we'll give out 10 $100 gift cards. And so visit the exhibit hall. I think in your packets you have a little bingo sheet to fill out. And if you do, you'll be eligible to win the $100 gift card. We'll give out 10, like I said. And winners will be announced at the end of the course, and you must be present to win. Some housekeeping, so that we do have Wi-Fi. The name is CU Anschutz Guest. You just have to agree to the campus network policy to connect. Please be sure to pay for parking via the Park mobile app or at a pay station in the lot that you parked in, so that hopefully you don't receive a parking ticket from the campus here. And then meals, we will have, in addition to food and snacks outside, we do have lunch at 11:50, and we have a snack and networking. We're calling it a reception. It's essentially a happy hour at 2 o'clock on the rooftop of this building, and should have a nice view of the mountains, and there's food and drinks later today up there. Hand this over to Debbie. Here you go.
All right, so just some more housekeeping. So in terms of this conference today, just make sure you checked in today, including to make sure you get CME, MOC, or nursing contact hours. You can look online on the website to get information about this. We'll also provide this link a couple times today, so you just make sure you don't forget. Here's some specific information about the CME credits as well as the ABIM MOC points. And then here are a few disclosures that a few of our speakers today have, including Dr. Click and Dr. Menard Ketcher, who will be speaking later today. Once again, so in terms of the credits today, you can take a look at this using this QR code or this website here in terms of claiming your credit. The evaluation will close on Sunday, August 25th at 5 p.m. And then you're going to receive an email with the CME certificate on Monday, August 26th. Here's some more information in terms of the NCPD disclosure, so you can take a look here. And then here is the QR code for the NCPD nursing contact hours. This is also available at the check-in desk.
All right, so we just want to acknowledge our sponsors and thank our sponsors and our educational grants today. So we have Janssen and Olympus to thank you for that. Again, don't forget to visit the exhibit hall, all of our sponsors outside to win one of 10 $100 gift cards, as Avash mentioned. And we want to thank our exhibitors, Takeda as a gold exhibitor today, silver exhibitors, Olympus. And our bronze exhibitors today are AbbVie Digestive, AbbVie Hepatology, Braintree, part of Sabella Pharma, Cook Medical, Exelixis, Gilead Sciences, Hep B, Intercept Pharmaceuticals, Madrigal Pharmaceuticals, Microtech Endoscopy Interscope, Avesco Endoscopy, Fathom Pharmaceuticals, Sanofi, AbbVie GI Care, Ardelyx, Bristol Myers Squibb, Castle Biosciences, Fujifilm Healthcare Americas, Gilead Sciences Liver Disease, Janssen, Mallinckrodt Pharmaceuticals, Medtronic, Orphalin, Pfizer, and Salix Pharmaceuticals. Thank you so much for being here. All right. So as we kick off our first session today in high yield topics in luminal gastroenterology, we ask that all of our speakers for this session please make their way up to the stage. So our first speaker today, I'll give, yep, all of you, yeah, head on up. So our first speaker today is Dr. Ben Castle. He's our assistant professor of medicine. He works here at the VA, Highlands Ranch, and the university, and he's going to give us updates in gastroparesis today. Thank you, Ben, for being here.
Thank you, Kelly. So as Kelly mentioned, I'm an assistant professor here, and Avash reminded me that when Kelly and Avash started a fellowship, that's when I started on faculty, so that can kind of place us in time-wise. I will have poll everywhere questions. I don't know if we need to register, people sign up. Will they be available on the first question? Okay. So again, thank you for inviting me to talk today. I'll be talking about gastroparesis. So here are my objectives for the talk. By the end, you should be able to order and interpret appropriate diagnostic tests, understand the role of GLP-1 agonist in symptom generation, describe the risks and benefits of pharmacologic therapy agents, and implement pylorus-directed therapies in appropriate patients. And finally, and most importantly, be confident in managing these patients. So I'd like to use a case to kind of guide us through the course today. Our patient is a 57-year-old woman with poorly controlled diabetes who presents to your office with a 9-month history of nausea, vomiting, and early satiety. Her symptoms have progressively been getting worse, and she has recently started to lose weight. An EGD is done, which shows a moderate amount of retained food in her stomach, but was otherwise normal. What do you think is the next step? And so this will be our next first poll question. So if you guys want to use the link up there or text to the number or use the QR code and just kind of weigh in what you think the next step should be to diagnose our patient. Okay, seeing a lot of people picking the gastric emptying scan, but which is the right gastric emptying scan? Okay. Let's give it a few more seconds and we'll move on here. Okay, I think we can move on. So it seems most people pick option C, gastric emptying scan of at least 3 hours duration, and that is the right answer. Okay, so according to the 2022 ACG guidelines, a gastric emptying study of at least 3 hours duration is the standard for diagnosis. It should ideally be extended to 4 hours, but can be stopped at 3 hours if more than 90% of the meal has been emptied. And gastroparesis is defined by greater than 10% retention at the end of 4 hours. It has been shown that delayed emptying on a gastric emptying scan correlates with gastroparesis symptoms. However, it has also been shown that retained food, I saw some people selected this, is not very reliable predictor of gastroparesis, and you can see the test characteristics there. So our patient comes back to you after her gastric emptying study with 15% retained contents at 4 hours. She returns to your office for follow-up, and you again review her medication list. Take a look at this list and see if anything seems potentially problematic to you, and then we'll go to our next poll question. Okay, there we go. Okay, seems like everyone is kind of keying in on the semaglutide, understandably. I think we can go back to the presentation. So yeah, we note that she's on semaglutide for her diabetes. You guys all kind of keyed on that. Good. You seem to be all aware that semaglutide is in a class of drugs called GLP-1 agonists, and these have been the source of much attention in the medical and lay press recently. Just as kind of a fun fact, exenatide, which was the first GLP-1 agonist released, is actually a synthetic version of component in the venom of our friend, the Gila monster here. So I want to talk about what GLP-1 or glucagon-like peptide 1 is. It is a member of a class of hormones called the incretins, and these are hormones that are secreted by the intestines and work to lower blood glucose. As you can see in this diagram, GLP-1 has many effects throughout the body, but what we'll talk about today is its effect to slow gastric emptying. The physiologic reason for this is to control release of food from the stomach into the duodenum and modulate postprandial hyperglycemia. Given its ability to lower glucose and to cause weight loss, synthetic agonists of GLP-1 have become increasingly popular, as you can see in this graph using data from the University of California system. However, as you guys are certainly aware, they are not without their issues. For this talk, as I mentioned, we'll talk about their effect on delaying gastric emptying. When given to healthy controls in one study, 57% of these enrollees had delayed gastric emptying. Of note, of those 57% who had delayed emptying, only 49% still had delayed emptying at 16 weeks. Interestingly, a couple of studies have shown that this delaying effect may be attenuated or even absent in patients with pre-existing gastroparesis. However, I do think it's worthwhile that if you have a patient that has symptomatic gastroparesis who is on one of these medications, to reach out to have them or you on your own reach out to their PCP or their endocrinologist to talk about other options for controlling their diabetes. So you have this discussion with our patient. She stops her semaglutide, but unfortunately comes back several months later and is still pretty symptomatic. She asks you, isn't there some type of pill I can take for this? So this will be our next poll question. And it'll be, when it comes up, it'll be what medication would you choose as your first choice for a patient with gastroparesis? Okay, I'll wait a few more seconds here. Okay, I think we can move back to the talk. So most of you picked metoclopramide, which is good because that's what my slide is about. This is actually the only FDA-approved treatment for gastroparesis. It's a dopamine and serotonin receptor antagonist and works on receptors in the stomach to stimulate motility and also blocks transmission in the emesis center of the brain. It has been shown to improve both gastric emptying and gastroparesis symptoms. However, I'm sure that most of you here are aware about the black box warning for tardive dyskinesia. I'd like to talk a little bit more about that. So the actual risk is not super clear. The FDA does not provide numbers. Older reviews of gastroparesis quote a risk of anywhere from 1 to 15%. However, it appears that based on more recent studies that the risk is much lower than that. A VA study found no increased risk for tardive dyskinesia in patients on metoclopramide compared to controls that were not on this medication. The risk may be as low as 0.1% per 1,000 patient years based on a review from 2019. And a review of the FDA Adverse Event Reporting Database showed just under 5,000 reports of adverse neurologic outcomes and just under 1,000 reports of tardive dyskinesia amongst over 40 million prescriptions for metoclopramide. It is worth noting here that minor or reversible symptoms may not be reported in these databases. The authors of the FDA study also noted that adverse event reporting initiated by lawyers spiked significantly after the FDA black box warning was issued, as illustrated in this graph here. Even if the risk is small, given that we are talking about potentially irreversible symptoms, I think it is still worth taking some time and taking some steps to minimize this adverse outcome. Listed here are risk factors for patients more likely to have neurologic side effects from metoclopramide, with whom you might want to be more vigilant or consider using a different agent. I think it is best practice to provide informed consent and discuss the risk of potentially irreversible symptoms with your patients, to use the lowest effective dose that controls their symptoms, as the risk does appear to be dose dependent, and to only prescribe 90 days at a time so that symptom checks can occur on a regular basis. Drug holidays or dose reductions should be done, and you as clinicians should be vigilant for any symptoms and be prepared to stop and replace with alternative therapy. A couple of other options that were on the poll. Domperidone has the same mechanism of action as metoclopramide and has been shown to have similar efficacy, but without reports of neurologic side effects. The major issue with domperidone is it is not easily available in this country. However, we have had success getting it for our patients from mail order Canadian pharmacies. Macrolide antibiotics have also been shown to be beneficial. Erythromycin is the most studied. However, there is some data that suggests azithromycin and clarithromycin may also be effective. The major issue with erythromycin is tachyphylaxis. This can be avoided by only giving it a few weeks at a time with a washout period in between. Metoclopramide, domperidone, and macrolides can all cause QT prolongation, and a baseline EKG should be obtained and reviewed. Finally, and for the drug talk, I wanted to talk about prucalopride. This is FDA approved for constipation and works by stimulating 5-hydroxytryptamine 4 receptors in the colon, leading to increased motility. However, these receptors are also present in the stomach and small bowel and have a similar promotility effect. Based on this, you might expect that prucalopride might have some benefit in patients with gastroparesis. However, the evidence is somewhat mixed. A randomized controlled trial from 2019 in Europe showed improved emptying of symptoms in patients with gastroparesis. However, a more recent study showed no symptomatic benefit despite improvements in emptying. Anecdotally, and I think some of my colleagues here have had some success using this in patients with gastroparesis and constipation. However, insurance coverage and costs can be a significant issue for this medication. One thing to mention, prucalopride does not prolong the QT interval like the other agents do. So going back to our case, our patient is concerned about side effects from metoclopramide and is unsure if she can navigate the process of obtaining domperidone from a foreign pharmacy. She does not have constipation, and prucalopride is unlikely to be covered by her insurance. Frustrated given lack of options, she asks you, isn't there some procedure you can do to fix this? So this is our last poll question, and this is going to be a word cloud. I know Dr. Patel is a fan of these. So just type in on your phone any procedure you can think of you think is helpful for gastroparesis. And if you're not familiar, the way this works is the more people put in one thing, the larger it will appear on the screen. So we'll wait for it to come up. Okay, looks like we are there. So we can move back to the talk. So most people saying G-POEM and Botox. You might notice that both of these are interventions directed at the pylorus, which, even though I didn't really think about it this way, it does make sense since the pylorus is kind of the ultimate and final step for gastric emptying. And we do know that a significant number of patients with gastroparesis have pyloric dysfunction. The first study that looked at this almost 40 years ago found that 14 out of 24 patients with diabetic gastroparesis had a finding that was termed in the study of pylorus spasm. We'll get back to that in a minute. Most people talked about G-POEM. So G-POEM, or gastric peroral endoscopic pyloromyotomy, is an intervention that has a lot of relevant and recent interest. The steps of this procedure are shown in this slide and involve creating a submucosal tunnel from the proximal antrum to the pylorus, which is then cut with an endoscopic knife, and then the scope is withdrawn and the mucosal entry site is closed with clips. This procedure has proven to have significant positive results. The study on the left from 2022 shows durable response in terms of symptoms, with 56% of patients having a 25% decrease in their gastroparesis cardinal symptom index, or GCSI scores, at 12 months post-procedure. The Martinex study on the right is a randomized sham-controlled crossover study which showed a 50% drop in GCSI scores at 6 months in 71% of the initial treatment group and 75% of the crossover group. Finally, a meta-analysis done in 2020, consisting of 10 studies of nearly 300 patients, showed symptom improvement in 85% of cases and a decrease in GCSI scores of approximately 50%. The other thing that people mentioned a lot was Botox injection. So intrapyloric botulinum toxin injection despite being a less invasive approach than GPOEM, is actually not currently recommended by the ACG guidelines. The 2013 version of the guideline cites 2 randomized controlled studies which showed no benefit over placebo. However, that version of the guideline said, quote, there is a need for further study in patients with documented pylorospasm. So almost 10 years after these guidelines were released and this statement was made, has there been further study of these patients? And what is the best way to assess for pylorospasm? The answer to the first question is unsurprisingly yes. And the answer to the second question, unless you have access to a water-perfused anteroduodenal manometry catheter and someone trained to use it, is potentially a technology called EndoFlip. So actually, the Medtronic rep here has an EndoFlip device out there. So you can look at it in between sessions, but EndoFlip is an endoscopic luminal function imaging probe. It is a balloon that has multiple sensors along a central catheter, as well as electrodes at the end. The balloon is inflated, and the sensors use impedance to measure cross-sectional area, or CSA. Pressure transducers measure pressure within the balloon. These measurements can be used to calculate various parameters. Most relevant for this talk is the sensibility index, which is defined as the CSA divided by pressure. And this is a marker of how readily the lumen distends with balloon inflation. This has predominantly been used in esophageal disorders, but there is a growing body of literature around its use in gastroparesis. So studies have shown that gastroparesis symptoms are inversely correlated with CSA and pyloric diameter. The pyloric distensibility index, or PDI, has been shown to be lower in gastroparetics than in healthy controls, and lower PDI correlates with worse gastroparesis symptoms. The image that you can see here is the visual output of the EndoFlip device with a balloon across the pylorus, with a healthy volunteer on the left and a gastroparesis patient on the right. As you can see, the gastroparesis patient has a much narrower area of the pylorus and has a higher pressure within the balloon. Extrapolating from this, we can see that pyloric flip can be used to identify patients likely to respond to pyloric interventions, as shown by the 2 studies on the left with pyloric balloon dilation and pyloric botulinum toxin injection. It can also be used to assess for efficacy of pyloric interventions, as shown by the studies of ESOFlip dilation and GPOEM. So to wrap up our case, our patient ends up deciding to get domperidone from a Canadian pharmacy and finds the process easier than she expected. She has good control of her symptoms, and she understands there are other options, including procedural options, available for her symptoms. She is very grateful to you for managing her distressing symptoms. So to recap, I don't think my recap slide got put in here, but a scintigraphic gastric emptying scan of at least 3 hours duration is the gold standard for diagnosis. GLP-1 agonists can delay gastric emptying and should be sought out on your patient's medication lists. There are several pharmacologic options for gastroparesis. Metoclopramide is the only one with FDA approval. The risk of neurologic side effects with metoclopramide is likely very low, and I think it can be used safely as long as you remain vigilant. Prucalopride is worth trying in patients that also have constipation. GPOEM, where available, is a good option for patients with refractory symptoms, and pyloric flip can potentially be used to identify patients likely to respond to GPOEM and other pyloric interventions such as botulinum and toxin injection. Thank you for listening and participating in the talk today, and I want to thank the course directors again for inviting me to speak tonight.
Thank you, Dr. Castle. That was a great lecture. Appreciate that. Sometimes a frustrating disease and a wonderful update. So our next speaker is Dr. Cale Steiner. He's an assistant professor of medicine, and he will give us updates in management of inflammatory bowel disease.
There we go. Thank you. Yeah, so I'm Cale. I'm one of the IBD faculty here. Also want to thank everyone for coming out. Thank the directors for inviting me to give this talk. So is there a, oh, this? Boom. Okay. All right. So yeah, I'm talking to you guys today about updates in management of inflammatory bowel disease. So, you know, a really narrow topic where 20 minutes is definitely going to be enough time to cover everything you need to know. a kid, I had to pick a couple things to talk about. So no disclosures, unfortunately, and outline today. So again, this is a very broad topic, and I don't expect anyone to leave here an IBD expert based on this talk, but I tried to pull four things that I thought were very salient to our practice, very salient to what we do every day in the IBD clinic here. And that you should keep in mind when you're treating patients at all levels, when you're interacting with patients with Crohn's disease or ulcerative colitis. So starting with the first one, treat to target. So this is, topically, this is kind of a simple topic, but there is some nuance to it. And I think it's important to be very intentional with how you think about treating your patients when they come in with IBD, particularly with a flare. And I think probably most of us know kind of the basics. I just wanted to put this into a framework for everyone to think about when they're treating these patients. And I was helped in this by a fairly recent paper called STRIDE 2. And this was a consensus paper. A bunch of experts got together and talked about how you should manage IBD, starting with when they either have active IBD from a flare or a new diagnosis. So I think about this kind of in 3 time points. So when a patient comes in and they have active IBD, you're going to choose their therapy based off of how severe they are, personal factors, et cetera. And then you want to think about this in terms of short, intermediate, and long-term targets. And I'll go back to this diagram at the end and kind of go over what those targets are. But in a stepwise fashion, in this STRIDE 2 paper, essentially they started off talking about short-term targets, and they asked the experts to kind of rank these things. On this graph, a lower score means more important. So when talking about short-term targets, you can see that for both Crohn's and UC, clinical remission, clinical response are very high up there. Endoscopic response is also high up there. A little lower down, you want normalization of your biomarkers. And then here at the bottom, the transmural healing, the histological healing piece, I'll hit on that later, but those really are not part of our treat to target goals at this point. So for your short-term targets, what do I mean when I say clinical response? Well, they define it in this as essentially a 50% decrease in symptoms. They mentioned the PRO2, this stands for patient reported outcomes 2. And for Crohn's, you're essentially looking for improvement in abdominal pain and stool frequency. For UC, you're looking at improvement in rectal bleeding and stool frequency. And the short-term targets, I meant to talk about what the short, intermediate, long-term is. To me, a short-term target is weeks to a month or 2. So when I have a patient that I'm going to start on a therapy, within the first few weeks to a month or 2, I really want to see at least this 50% reduction in clinical symptoms. When you're moving on to the intermediate targets, so here I'm talking about a few months to maybe 6 to 9 months. And in that time frame, you really want to achieve that clinical remission goal. So what does that mean for our Crohn's patients? Essentially no pain and almost a normal stool frequency. And then for ulcerative colitis, you want to see essentially no rectal bleeding and normal stool frequency. And this intermediate time point is really when those biomarkers become a little more helpful. Now, you certainly want to see a reduction in biomarkers when you first start someone on a therapy. If your CRP is going up after their first 2 doses of infliximab, for example, that's certainly a problem. But you want to aim for that normalization in that intermediate time frame. And so for CRP, essentially, we want to see full normalization. Here in this paper, they say fecal calpro 1 to 250. I think there is some gray there. Most assays say over 50 is elevated, and I think most of us in IBD are really okay with a 50 to 100, maybe even 150. I think 250, if I had a patient that had 250, I don't know that I'd be really excited about that. So keep in mind there is some wiggle room in this range, but you want that fecal calprotectin to be as low as you can. For me, I tend to aim for about 100, maybe 150 if clinically they're doing really, really well. And then the long-term targets come in, and what we're really talking about here is our endoscopic healing. When therapies first started coming out for IBD, it was really primarily clinically driven outcomes. And it's not recent that we switched to recognize how important endoscopic healing is, but I think it's important to really reiterate that you want endoscopic healing in your patients. And so I scope all my patients after about 6 to 9 months, anytime I do an escalation or a change of therapy. And I use this SES-CD score, simple endoscopic score for Crohn's disease, and the Mayo subscore. There are a lot of scores out there, but the bottom line is you just want to have essentially normal. So an SES-CD under 3 means no disease. 3 to 7 is mild, 7 to 15 intermediate, and then over 15 you're in trouble. And then the Mayo score, obviously 0 means you're not seeing any inflammation on endoscopy. So 2 points I do want to make here when you're talking about long-term targets. There are a lot of good reviews out there about kind of being weary of letting perfect be the enemy of a job well done here. And so what do I mean by that? I'm telling you endoscopic healing is so important. But but don't worry about being perfect. What I mean is we do have, it's not uncommon to have patients who, for example, have achieved clinical remission. They feel fantastic. They're tolerating their biologic well, and you go in and look, and they might have like patchy Mayo 1 disease, or perhaps an SES-CD score of 4 instead of 3. And what do you do there? That's a nuanced decision, and for me, that usually comes back to a discussion with the patient. But if you don't underestimate the risk of switching therapies, if everything else looks good and they have just some minimal endoscopic inflammation, I think that's a time when perhaps if they're not maximized on their dosage for their therapy, I would definitely consider increasing the dose there. But I would be very wary of necessarily changing an therapy entirely after 6 to 9 months after achieving clinical remission, normalization of biomarkers, just because you didn't quite hit this endpoint. So I put that little caveat up there. And then the last thing I want to mention on treat to target is histologic remission, transmural healing. A lot more information is coming out about these. You can guess, it goes kind of makes sense that most papers, they're all retrospective, that look at histologic remission and see if they're associated with better outcomes. Well, they are, and that makes sense. But we don't have any prospective data. We don't have any really proof that if everything else looks great, if they just have a little bit of mild activity on biopsy, if going after that with aggressively does any good. And so right now, it's important to know these are not a part of treat to target. I like this information. I like getting it, and it helps inform complicated decisions, but it's not part of our treat to target right now, histologic remission nor transmural healing. So just quickly back to this, the last thing I wanted to mention on, so, short term, weeks to months, you want that symptomatic response followed as quickly as possible by normalization of biomarkers and clinical remission. Don't forget that you need to do an endoscopic evaluation aiming for no inflammation. And don't forget about this quality of life piece. A lot of our patients with IBD have very complicated phenotypes. And so, don't discount this. Don't forget that in the absence, or even if all the objective measures look good, continue to assess how your patient's doing. And I think that's why a lot of our practices, ours included, now have, for example, psychology, ancillary services and dietary services and these sorts of things to try and help these patients get back to a good quality of life. All right, that was quick. Next topic, top-down therapy and Crohn's disease. So what are we talking about? What is top-down therapy and what is the alternative? So essentially we're talking about step-up therapy versus top-down. Top-down is when you start with a biologic, and you can do this either as a monotherapy or in conjunction with an immunomodulator at the time of diagnosis, and this is often done before your steroid taper is done. Step up is waiting and seeing if the steroid taper works, kind of getting the patient off steroids, starting an immunomodulator if they still have symptoms, and then only adding a biologic later if they continue to have clinical symptoms despite the immunomodulator. And, in my practice, and I think in a lot of our practices, top-down therapy for Crohn's has really pretty clearly been proven to be the best way to go for this. I think this started really with Sonic was the first kind of prospective study. This was done in 2010 that showed either a biologic monotherapy or combo therapy was superior to just an immunomodulator by itself. And this is a newer trial that just came out earlier this year that really just hammered that point home. So interestingly, the study was actually looking to validate a biomarker for inflammation, and that failed. The biomarker was not useful. But in the course of doing that, they did split their patients into a step-up and a top-down therapy group and assessed outcomes. So these were newly diagnosed Crohn's disease patients, active disease. There was about 193 patients in each group, and they were stratified to step up or top down. And so what that meant was the top down group during the steroid taper, oh, there is. So you can see these were all patients, they were started on a steroid taper. So, it's a critical part of getting these folks clinical response and induction therapy. Before that was even done, if they were in the top-down therapy, they were started on infliximab and an immunomodulator. If they were on the step-up therapy, they were essentially assessed if they had ongoing symptoms. If they continued to have symptoms or a flare, then they were escalated to an immunomodulator. If they flared again, then they were put on a biologic therapy. And this, again, just summarizes that what they did, essentially starting with an immunomodulator up front, increasing the dose of that immunomodulator if there was a flare, versus not starting an immunomodulator, or a biologic, increasing the dose of the biologic if there was a flare, versus completing the taper, considering an immunomodulator, considering later upping to a biologic. And so this pretty clearly showed that the top-down therapy was better. So for patients that reached the primary outcome, which was steroid-free, surgery-free remission, 64% more patients on the top-down were able to achieve that. 23% more were able to achieve endoscopic remission. Pretty much all of the secondary outcomes were in favor of top-down therapy approach. And the safety profiles were really similar. I'm not going to go through everything on here, obviously, but really, the biggest risk factor was flare of Crohn's disease, which was higher in the step-up group. So it was pretty clear that safety-wise, top-down therapy was not any worse, in fact, maybe better. So to summarize that, top-down therapy, when someone comes to your clinic, they have active Crohn's disease, new diagnosis or a flare, don't hesitate to start a biologic therapy early and be aggressive with that. All right, so therapeutic drug monitoring. I am admittedly wading into some murky waters to talk about this because there is not complete consensus, particularly with regard to proactive TDM. But it is so important that I felt like I should at least address it, kind of give a quick overview of what it means, what we're talking about, and how we use it in our practice. So the first things to kind of know are there are two types of therapeutic drug monitoring. And I'm just going to say TDM from now on because it's easier to say. So proactive is you systematically measure your drug trough and antibodies regardless of clinical symptoms, no matter how the patient's doing. And you adjust the therapy, the dosage based on that. Reactive is essentially you check the drug levels and the antibodies when you have a reason to, particularly treatment failure, secondary or primary loss of response, or if the patient's taken a drug holiday. And so there is some debate as far as proactive TDM and when you should use it. So I'm not going to talk a whole lot about proactive TDM, but I do want to reiterate that reactive TDM is really standard of care at this point. So when should you do reactive TDM? Anytime your patient has a confirmed primary loss of response or primary non-response or secondary loss of response. Also, if you're thinking about discontinuing or changing the therapy, you really got to check the levels. And I want to reiterate here that you got to be careful with the anti-TNFs calling them treatment failures until you know that they're in this 10 to 15 level. And I actually like to see it even a little bit higher sometimes. But if they're on an anti-TNF agent and they're not doing well, but their drug level is still low, I would hesitate or I would not call that a treatment failure. I would accelerate the dosing until you're at maximum dose. It is, I am going to talk about proactive TDM. At the bottom here, reactive TDM in patients on basically biologics other than anti-TNFs. The levels that you need to achieve are less clear, and how to really utilize that in practice is less well delineated, but I think we are going to get there. It's just not there yet. There's still a lot of gray area in reactive TDM for the non-anti-TNF biologics. A couple times when you should think about proactive TDM, when I think about proactive TDM, this was actually the Red Journal. It's a recent update in guidelines. This is a consensus guideline again on TDM. Number 10 and 11, they basically say proactive anytime you have induction and at least once during maintenance therapy. I don't always do that, and I think that's where there's some gray area in the field. But I do really think about proactive TDM when you have a severely active patient, if it's someone who has higher drug clearance, and also if you want to optimize monotherapy. So if you're going into the patient using monotherapy and not going to do a combination with an immunomodulator, that's someone you might want to think about doing proactive drug monitoring. And then the last things I wanted to hit on this is just be aware, increased clearance, what is that associated with? Well, male gender, low albumin, high CRP, high BMI. If you have a patient with a lot of those risk factors, that's someone you would want to consider doing proactive TDM in. Anytime you have a drug holiday, I wanted to hit on that really quick as well. You want to do TDM on that patient. Particularly, so generally what you'll do is you'd restart the drug they were on a holiday on, and then after that first dose, check a level in antibody. And what you're really looking for is making sure they don't now have antibodies because of the drug holiday before you would give them their next dose. And then be aware that a lot of these assays have some variability. So if you can use the same assay every time for a patient, that's going to be more beneficial. They're not quite uniform how all these assays are run yet. All right, so last topic. I'm not going to talk about all the new drugs and all the new things in the pipeline. There are a lot of them, and the list is ever growing, which is good. But two things I did want to hit on today, because I think they have potential to make a lot of patients' lives better, are the subcutaneous formulations of infliximab and vedolizumab, because these were recently approved. And so briefly, Sub-Q vedolizumab was looked at in UC and Crohn's in the VISIBLE-1, VISIBLE-2 trials. Essentially what this was is they got 2 IV doses of the vedolizumab, and then for that third induction dose, or what would have been the third induction dose, they were switched over to the subcutaneous formulation. And it's 108 milligrams every 2 weeks. And the study confirmed, looking at clinical endpoints and for UC endoscopic endpoints, non-inferiority. So patients that were, they were randomized either to continued IV or to sub-Q. Sub-Q was non-inferior to IV. And that was borne out in the Crohn's disease studies as well, although they look primarily at clinical endpoints for this one. And then there is one small study so far that has looked at switching. And so this is not patients who you are starting on Entyvio with the intention of putting on sub-Q. This is patients who are on IV vedolizumab for at least 6 months. They followed these patients for 18 months, and about 74% of them were still on the subcutaneous Entyvio. So I think the takeaway is that if you have a patient who really wants to be on a sub-Q formulation, even if they've been on IV forever, it's worth a try. It's worth a try switching them because there's a good chance they're going to have sustained remission or sustained improvement from the subcutaneous. And then similar to vedolizumab, infliximab was looked at as a switching to subcutaneous versus staying on IV after the first 3 induction doses. And this study looked at kind of all IBD, it included UC and Crohn's disease. And again, it showed non-inferiority, both in clinical remission and response rates and in adverse events. And then there was a study where they switched people similar to the vedolizumab, switching from IV to the sub-Q. And what they did, these are patients, some of these patients had IBD for a long time. You can see the average duration was 13 and a half years, but a big variability there with a 9.4 plus minus. But so what they saw was that in these patients down here, on the green, yellow, orange, and red are different dosages. And so it's essentially 5Q8, 10Q8, 10Q6, and 10Q4. For these 3 doses, it was really non-inferior, switching to subcutaneous infliximab. Patients, well, it shouldn't have non-inferior, was not head-to-head, but it was, they did fine. A lot of them were able to maintain the subcutaneous infliximab, but a lot of patients in the 10 milligrams every 4 weeks group did have flares. Of note, they were able to recapture response and remission in about 94% of them when they either increased the subcutaneous dose or when they switched them back to IV. And so what that came out recommending was that basically if you have an IBD patient who's treated with infliximab and they want to switch to subcutaneous, if they're on a 10 milligram Q4 week regimen, you should switch them over to 240 every other week. If they're on the lower doses, then starting at 120 every other week is a reasonable strategy. I don't think we really know exactly how and where to position these therapies yet. I'm certainly not proactively trying to switch all my patients over to subcutaneous, but if you have a compelling reason to put a patient on subcutaneous therapy, if you really want them on an anti-TNF, but they are really opposed to the IV formulations, these are options you can consider. I think the jury is still out on long-term data. This is all kind of short-term stuff, but it is an exciting new addition to our repertoire, especially for patients for whom IV dosing is difficult or not favorable. So just to kind of wrap it all up, so treat to target, really looking at clinical response, clinical remission in the short term, followed by biological and endoscopic remission. Histological remission can be a useful data point, but it is not a target. And don't let perfect be the enemy of a job well done. Top-down therapy, pretty solidified now. Brand new study came out. Really important to start with a biologic therapy up front for patients with Crohn's disease. Don't step up therapy has been proven inferior multiple times. Therapeutic drug monitoring, this is a useful tool. Reactive therapeutic drug monitoring is really standard of care. Whether or not you do proactive therapeutic drug monitoring is kind of patient dependent, at least for now. And then lastly, subcutaneous infliximab and vedolizumab, 2 new drugs on the block, or new formulations rather, and hopefully a lot of patients get some benefit from that if they don't want to do IV dosing. So that's all I got. Thank you to everyone. Thanks again.
Thank you, Dr. Steiner. Great talk. All right, next is Dr. Swati Patel, our former course director of Rocky Mountain Highlights, and she is an associate professor of medicine here. Will give updates in hereditary colon cancer.
Morning, everyone. It's great to be here. Congratulations to the course directors and Christy, Lindsay, and Matthew for really putting on an amazing course. It's going to be a great day. So I've been asked to give an update in hereditary cancer syndromes. This is obviously a vast topic. And so like Kale, I decided to kind of focus on, I think, some of the most exciting things happening in the field. So the reality is we can't cover everything. For those of you who have been stuck with me in an endoscopy room know that I could talk about this all day long. But for the next 20 minutes or so, I'll just focus on some really important updates in Lynch syndrome, which is a very, very common condition that probably, whether we know it or not, each and every one of us have interacted with somebody who has Lynch syndrome. So we'll talk about why people with Lynch syndrome get colon cancer and how maybe their cancer is a little bit different than cancers that other individuals get. What we recommend for patients currently who have Lynch syndrome to decrease their colon cancer risk, but really understanding the limitations of what we currently offer. And then tie up with talking about some of the more exciting changes or innovations in the field to further decrease cancer risk for these patients. So Lynch syndrome is very common. It actually accounts for up to 5% of all colon cancer diagnoses. 1 in 279 individuals in the general population have Lynch syndrome. So in fact, it's more common than BRCA 1 and 2, and just as common as some of the very important conditions that we take care of in GI, like celiac disease, inflammatory bowel disease, which we've been hearing about today. It's caused by an inheritance of a mistake or a mutation in one of 5 genes. And these are genes in the family that we call mismatch repair genes. And you can see the specific genes listed: MLH1, MSH2, MSH6, PMS2. And then EpCAM is actually just a gene that lives upstream of MSH2. And a mistake or a mutation in EpCAM can actually cause dysfunction of MSH2, and patients look like they have MSH2 Lynch. So if you excuse me for a moment to just nerd out for a second, I'll show you what these mismatch repair genes actually do. They create these proteins called mismatch repair proteins, right? So if we go back to biology 101, genes, genetic code, our DNA creates RNA, which then creates a protein. And so these mismatch repair proteins are fairly sophisticated. They essentially, in the genetic code, find mistakes, excise them, so they repair mistakes. And we know mistakes happen, right? So every time a cell divides, this happens millions and millions of times in every cell of every organ of our body, mistakes are just bound to happen. And so, for instance, if there's abnormal insertion, as you see here, these mismatch repair proteins find it and they repair it. And that genetic code kind of persists as it normally should, creating the normal protein products of that genetic code. Unfortunately, if that mismatch repair function is not working, then these mistakes can kind of get incorporated into the genetic code of a cell. And this is really the hallmark of Lynch syndrome, because mismatch repair functions down. And so you essentially get these repeated insertions of code where they're not supposed to be. And that's what we call microsatellite instability. And you can imagine that if these mistakes build up in important genes, right? Genes that are responsible for how cells move, how they divide, how they grow, what we call oncogenes or tumor suppressor genes, then essentially those cells grow abnormally. They pass those mistakes on to the next generation of cells. And you can see how these things can lead to abnormal growths, precancer, and cancer. And when the fundamental problem is that that individual can't fix mistakes, well, you can imagine how this is a snowball effect, where mistakes beget more mistakes, and this process can accumulate really quickly. And so when we think about colon cancer, or really any cancer, cancers in Lynch syndrome different. They look different than in the general population. So if we just do genetic sequencing of a colon tumor for a patient without Lynch syndrome or a microsatellite stable patient, you can see that the fundamental problem in that tumor is usually a mistake in 1 or 2 pretty important genes that regulate growth, the APC gene or P53. In contrast, when we do genetic sequencing of tumors in patients who have Lynch syndrome, there are mistakes all over the genome. Okay, so mutations all over the genetic code of the tumors of these patients. And so clinically, unfortunately, what that results in is patients who have a significantly increased risk of multi-organ cancer. So compared to the general population, you can see that it's not just an increased risk of colorectal cancer, but multitude cancers across the board that these patients are susceptible to. Now, all Lynch syndrome is not the same. I told you about those 4 genes, and they do look different clinically, with patients who have MLH1 and MSH2 Lynch having a higher lifetime risk. If they don't do anything or if they don't know about the diagnosis, can have up to a 60% chance of getting colon cancer, with MSH6 and PMS2 patients having a slightly lower risk. MSH6 around a 40% lifetime risk, PMS2 around a 20 to 30% lifetime risk. So one of the most powerful things that we as folks in the GI world can do is mitigate this cancer risk, right? And one of the most important ways we can do so is colonoscopy, because generally we believe that colon cancers start from small polyps that over time can grow and can turn into cancer. And during endoscopy, one of the most satisfying things that we can do is remove these polyps and essentially arrest that natural progression to cancer. And we really think that this works in Lynch syndrome. Early studies showed a significant reduction in getting colon cancer and dying from colon cancer, and subsequent studies summarized suggest that getting colonoscopy regularly can result in an 87% decreased risk of getting colon cancer and a 94% decreased risk of dying from it in Lynch syndrome. So based on this information, right, many of us who take care of these patients or are part of the endoscopy or clinic operation know that regular, frequent colonoscopy is an important part of risk reduction in these patients. And so the National Comprehensive Cancer Network is a body that puts out guidelines that kind of gives us some sense of how frequently and when we should be doing colonoscopy in these individuals. And based on the high risk that we see in MLH1 and MSH2 patients, with having earlier ages of onset, we really recommend colonoscopy starting at the age of 20 to 25 and repeating the colonoscopy every 1 to 2 years. This is really an intense colonoscopy screening program, but we do it because we think it works. For MSH6 and PMS2, because these patients have a lower lifetime risk, and if they do get cancer, it's a little bit later in life, we're able to start a little bit later, 30 to 35, and have some flexibility and maybe even extending intervals for them to adjust based on their personal situation, but sometimes even as spread out as every 3 years. So theoretically, based on what I've showed you, at least for one of these cancers, we should be able to nearly eliminate that risk. But unfortunately, that's not the end of the story. We know that colon cancer happens, post-colonoscopy colon cancer. Despite what we think is a complete or negative colonoscopy, we see patients come back with colon cancer even before their next due surveillance interval. Kind of provocative data, but data from Europe actually suggests that patients who know they have Lynch syndrome and are theoretically in surveillance programs actually have similar lifetime risks of getting colon cancer as those who don't. There's a lot of interesting kind of caveats to this data, but it certainly raises the question of whether colonoscopy on a population level for Lynch syndrome patients is actually accomplishing what we want it to. And this same group actually compared by countries. So they compared the rates of colon cancer in patients in Germany, where they do colonoscopy every 1 to 2 years like we do, versus Finland, where they do it every 3 years. And in fact, the Finnish patients seemed to have a lower risk, even though they were getting colonoscopy less frequently. And so this was really sort of disruptive in our way of thinking about what we have to offer our patients to decrease their colon cancer risk. So why is it that patients get colon cancer between colonoscopies? Well, we think that it boils down to kind of the same reasons we think about for post-colonoscopy colorectal cancer in the general population. Either we missed something on that colonoscopy, or we found it, but we didn't remove it completely, or perhaps something grew under our noses rapidly. So we know that missed lesions is a very, very, very important issue to address, certainly learning our lessons in the general population, but also in Lynch syndrome. This is a summary of studies that were done to actually look at technologies that could improve polyp detection rates, so narrowband imaging, other advanced imaging. But what I'd like to point out is this column on the right. they did these studies by basically doing tandem colonoscopies. And so, yes, there was an adjunct technique that they were studying, but really what we observed is that there are really high miss rates in colonoscopy, and these are specifically in Lynch syndrome populations. And even when we hone in on the studies that provide colonoscopy with contemporary technology, high definition scopes, miss rates were actually reported as almost 50%. So we miss things. And you might say, well, it's probably small things, little polyps here and there, but the reality is polyps in the general population and certainly in Lynch syndrome can be really, really subtle. And so the lights aren't dimmed, and probably if you squint, you can see the polyps here, but they're quite subtle. And with the narrowband imaging, you can see them demarcated a little bit better, but these are not insubstantial, tiny polyps. These are large polyps that certainly, if left in place, certainly could grow, could turn into cancer. And so we know missed lesions is an important issue. And just as we focus on the general population in terms of quality of inspection, it's an important kind of aspect of colonoscopy in Lynch syndrome as well. Incomplete resection, of course, once we find something, it's really important to remove it. It's important to remove it completely in everyone, in the general population as well, but particularly in Lynch, because we have this snowball effect that residual tissue could potentially rapidly grow and turn into something cancerous. So this is a study in the general population that was kind of a source of a lot of kind of humility in the field. This is where they took endoscopists and took out polyps and then asked the endoscopist to biopsy the periphery of what they thought was a complete polyp resection. There was actually a 23% incomplete resection rate up to that high. And when they looked at polyps 15 to 20 millimeters in size, the higher risk polyps, the incomplete resection rate was over 20%. And these sessile serrated lesions, which we know are really difficult to detect, but also have amorphous borders and look pretty similar to the surrounding mucosa, the incomplete resection rate was up to 31%. So this is really an important issue for all colonoscopists, but certainly in our Lynch syndrome patients. So yes, colonoscopy early and more frequently than the general population is really important for decreasing risk in these patients, but it's critical that it's high quality colonoscopy. And we all know about these issues, but a complete procedure to cecum, adequate bowel preparation, high definition equipment, and a meticulous endoscopist to not just find things, but when they find things, ensure they're removed completely. So in Lynch syndrome, we've noticed that even in the best of scenarios where patients are getting high quality frequent colonoscopy, sometimes cancers happen. And there's been a lot of attention to this third bubble here in Lynch syndrome. We talked about this snowball effect of mistakes just kind of building up. And really, this has been an area of kind of recent changes in Lynch syndrome where we're starting to understand that maybe even normal appearing tissue in the colon might have abnormal mismatch repair. So what we call these mismatch repair deficient crypts that can progress to a cancer in maybe a non-polypoid pathway, where it's not a polyp that we visibly can see and remove during colonoscopy, but that tissue is abnormal and it can turn into a cancer. And so perhaps this part of it in Lynch syndrome is a little bit more dominant than we think of it in the general population. So what can we do if colonoscopy is not our end-all be-all to decrease cancer risk in the Lynch syndrome patients? What can we do? And that's the most common question our patients ask us, right? They say, look, I'm going to try to come for my procedure. I'm going to try to do as best a job I can with the bowel prep, which is under my control. But doc, what else can I do? Are there any medicines? Can I change my diet? What about exercise? What about anything else in the field? So that's what we'll spend this last part of the talk reviewing. So actually, the most promising medicine in Lynch syndrome is quite simple. It's aspirin. This is data from the general population that showed that individuals who take aspirin in the general population for 5 years or so, 20 years down the line, have a decreased risk of getting colon cancer and dying of colon cancer. And so this has been shown over and over and over in the general population. Obviously, aspirin has been studied for a lot of cardiovascular indications, and they look at cancer outcomes in these trials, and they see this observed benefit in the general population. And so for this high-risk population in Lynch syndrome, there was quite a bit of excitement to study aspirin Lynch syndrome. And in fact, this UK group conducted a really important, large, international randomized controlled trial where they took individuals with Lynch syndrome and gave half of them a placebo, gave the other half 600 milligrams of aspirin. Now that's a really, really high dose. And the rationale for that dose is because this trial was designed back in the 1990s, where that's the dose that they thought they needed to get effect. But what they found is that over time, even 20 years of follow-up, there was a significant reduction in colon cancer incidence. This is really remarkable because this trial was 2 years. So patients took aspirin for 2 years, and then afterwards, whatever could have happened, placebo could have crossed over, the folks in the aspirin group could have continued or stopped. But even 20 years out, there appears to be a persistent protective benefit such that you really only have to treat 24 patients with aspirin to prevent one colon cancer. That is a really, really powerful effect size. So what do our guidelines say? Well, the NCCN really says to consider aspirin. And really the reason there's that caveat is because of that high 600 milligram dose, really making sure there's a shared decision, weighing all the other medicines and risk factors that a patient might have for bleeding, but that it should be considered. The Europeans, albeit, acknowledging that the level of evidence just based on one clinical trial is weak, are a little bit more strong in their recommendation, such that patients with Lynch syndrome should be offered aspirin. And that is what we do in our practice. And so our patients, we talk to them about aspirin, we make sure there's no contraindication or side effect that would make them not tolerate it. The main question that is left unanswered is what's the right dose? And we will have the answer to that question. So the follow-up study, the CAP3 study, finished recruitment in 2019, and they actually finished the last follow-up visit for the final patient about 6 weeks ago. So I think this year we'll know whether our equivalent of a baby aspirin versus a full dose aspirin versus that 600 is the superior dose, at least in terms of 5-year outcomes. But for now, I generally tell my patients that if they can tolerate a full dose aspirin, to start with that. And if they can't, then we can kind of adjust the dose to a baby aspirin, but probably some aspirin is better than none. What about diet? Well, the same CAP2 study group, actually there were 4 arms to that trial, also looked at resistant starch. And resistant starch, they initially hypothesized as decreasing the risk of colon cancer as we think about fiber and its protective benefits in colon cancer. What's interesting is that they didn't actually find a difference in colon cancer rates, but they did find a significant reduction in cancers outside the colon. So all these other cancers that we don't have great screening modalities for. They dialed down and looked at exactly what cancers were different between the two groups. It tended to be these upper GI digestive cancers, gastric, small bowel, pancreatic, biliary tree. And so right now, we don't fully understand that mechanism. It was a little bit surprising. Some think perhaps it's kind of a modulation or neutralization of carcinogenic effects of bile. But nonetheless, in this very well-designed placebo-controlled randomized controlled trial, they showed a significant reduction. And so we actually do recommend our patients take resistant starch as they're able to. And we've provided them with some information, green bananas, overnight oats. And where's Doug? I know Doug didn't tolerate the overnight oats, but there's lots of different ways to get this into their diet. And we've outlined recipes and different supplements, plantain powder, which you can buy, banana powder, also kind of thickening agents in curries and soups. But we encourage them to incorporate this into their diet if they can. Exercise. Well, this is still an evolving story, but the cool thing about exercise that's now coming out, which we know has some benefit, of course, that's shown in the general population in cancer risk reduction. This study offered Lynch syndrome patients participation where they did 3 times a week, 45 minutes of aerobic exercise. And though they weren't able to look at clinical outcomes, polyp rates, cancer rates, they were able to show an upregulation of protective kind of immune profile within the blood. So it's really an exciting area. And we're, of course, exercise is great for everyone in terms of overall health, but it probably also has protective benefits for our Lynch syndrome patients. And so finally, I'd like to talk about really an exciting development, and that is a vaccine to prevent cancer in Lynch syndrome. This really goes back to kind of an interesting observation in animal models where polyps are seen, but then they appear to spontaneously regress. And this has been reported clinically as well, where patients are found to have a polyp, they're referred for resection, and it has appeared to regress adjacent to a tattoo. And it's clear sort of what the mechanism exactly of what that has been over time. But the idea is that really our immune systems recognize these cancerous, precancerous things as foreign and actually can modulate that. And so this also sort of brings up this epidemiologic observation is what about what's going on in Finland? They do less colonoscopy and they're seeing less cancer. Is it that sometimes cancers are coming and going without us even knowing it and our immune systems handling it? So to the biology of Lynch, right? I told you that this mismatch repair problem causes mistakes, mutations all over the place. And so what that causes is a bunch of abnormal little peptides or proteins on these tumors. And what can happen is that either our immune system just can't really overcome that and the cancer progresses, or it can develop some kind of immunologic response to those neopeptides. So right now, if somebody has in Lynch syndrome some precancerous polyp or growth, there's a chance that our immune system or their immune system keeps it in check and it just stays in equilibrium and doesn't progress. There's also the chance that there's progression because the tumor basically overcame what the immune system was able to handle. So what if we were able to rev up that immune response and either keep people in this equilibrium phase or perhaps even allow that lesion to regress? So we've observed these kind of neopeptides that are fairly consistent across cancer types in individuals who have mismatch repair dysfunction. And there's been some investigation of vaccines in the cancer space. But what's really exciting is that some of these immune markers are actually consistent even in the precancer space. So polyps or these mismatch repair deficient crypts could be targets of revving up the immune system and keeping things in equilibrium or letting them regress. And so there's a clinical trial. It's actually the first kind of randomized controlled trial to look at this issue, where we're inviting patients with Lynch syndrome to participate, where they would get either placebo or a vaccine at 0, 4, and 8 weeks, and then a booster at 52 weeks. And the outcome of interest is whether patients get polyps or cancer at the 2-year endpoint. And we're one of several sites across the country that's participating. And so if you interact Lynch syndrome patients who might be interested in something like this, please don't hesitate to reach out. But it's very, very exciting because we are increasingly recognizing that although colonoscopy is really important, we need to offer our patients additional preventative options. So Lynch syndrome is very common. It's the most common hereditary GI syndrome. We have a lot to offer our patients in addition to high quality colonoscopy, medicines, lifestyle, and maybe even vaccines down the line. Appreciate everyone's attention and go Team USA.
Thank you, Dr. Patel. That's an illuminating lecture. Appreciate that. All right, next for this session is Dr. Ben Click, who will give us the updates in celiac disease. Welcome, Dr. Click.
Thanks, Kelly. Thanks to the organizers. And I'm sorry. And the reason I'm apologizing is because I must have wronged you all in some way. As an IBDologist, to be asked to speak about celiac disease is somewhat of a curveball. And then to follow Swathi Patel is probably the hardest act to follow that we have. So again, thank you for the opportunity. We'll give it our best shot here. These are my disclosures. None are relevant to the discussion we'll be having today. We'll be covering updates in epidemiology of celiac disease, diagnostic testing, treatment, monitoring, and treatment goals when evaluating individuals with celiac disease. What we know is that celiac disease is quite common. It rivals in terms of epidemiology other inflammatory bowel diseases, a global prevalence of about 1.4%. But what we've seen is that there's regional variation in celiac disease prevalence. And I've highlighted here some data from Colorado specifically, where we have a prevalence of about 2.4%. And that's just under the highest prevalence country, which is Sweden, followed by some other European countries and locales in the United States. So quite a high local prevalence in terms of celiac disease epidemiology. And like many other autoimmune diseases, we're seeing a rising incidence of celiac disease. So this graphic from a nice publication in the Red Journal shows that before 2000, it was still just like inflammatory bowel disease, somewhat limited to Northern European and North American countries, whereas after 2000, we're really seeing a rising incidence in those countries and somewhat related to increased recognition, diagnostics, but more likely as well a contribution from rising pathology and incidence truly. We know that celiac disease can, of course, cause gastrointestinal symptoms, and I won't bore you recapping that it causes diarrhea, bloating, sometimes abdominal pain, discomfort, cramping. But really what's interesting about celiac disease is there's a wide plethora of extraintestinal manifestations as well. So there's neurologic complications, there's bone-related manifestations, endocrine, oral, ocular, dermatologic, and again, it's kind of spreads the breadth of the organ systems in terms of its effects, impacts, and presentation. So always important to keep in mind these extraintestinal manifestations because they may be the only symptom that an individual presents with. There's some updated guidance from an ACG guideline published last year in the Red Journal about who should be tested for celiac disease. So of course, individuals coming into your clinic or you're seeing with diarrhea, weight loss, steatorrhea, pain, bloating, like I mentioned before, kind of the classic celiac disease symptoms should be tested. But individuals with atypical symptoms, extraintestinal manifestations should be considered as well. Laboratory abnormalities, and specifically those with isolated elevated transaminases as well as iron deficiency anemia should be considered for celiac testing. What's really interesting is individuals with a high risk of having celiac disease and potentially subclinical celiac disease. So individuals with a first-degree family member. So when taking that family history, you hear somebody in the family has celiac disease, that should prompt recognition that a first-degree relative should be evaluated and tested for celiac disease. And we'll talk about the methodology of testing in just a second here. But of course, genetic risk in celiac disease is quite prevalent. So monozygous twins, HLA-matched siblings, then siblings, still 20% risk of having celiac disease, and then parents and children followed by second-degree relatives. So clearly a genetic cascade in terms of risk. And then if greater than one individual in a celiac disease family, then all first and second-degree relatives should be tested. So there's clearly a genetic component to celiac disease and important to keep in mind when we're taking that family history. What's really interesting to me is this asymptomatic indication to tests and these comorbid conditions with high rates of prevalence of celiac disease. So type 1 diabetes, the estimated prevalence of celiacs up to 10%, autoimmune thyroiditis, autoimmune liver disease, individuals with Down syndrome, and microscopic colitis. So individuals particularly with lymphocytic colitis, which tends to present a bit younger than collagenous colitis, should also be considered for evaluating for celiac disease, particularly if their diarrheal symptoms thought to be related to their microscopic colitis aren't responding to traditional interventions. Celiac testing, we know, is largely antibody-based in this day and age. So our gold standard currently is the tissue transglutaminase antibody. And I put up this slide not to walk you through all the targets, but there are other antibodies that have historically been used as well, including the anti-deaminated gliadin, anti-gliadin, and anti-endomysial antibody, which has a high specificity for celiac disease. But I wanted to highlight the mechanism of assay used between the tissue transglutaminase and other antibodies as compared to the anti-endomysial. With the anti-endomysial antibody, it uses an immunofluorescence assay, and this is notoriously not only lab to lab variable, but it depends actually on the technician performing the test. So you can see wide ranges in test characteristics with the anti-endomysial antibody, which impacts its clinical utility and reliance, and that also impacts why we've now shifted towards the tissue transglutaminase antibody being the gold standard. With an IgA tissue transglutaminase, the sensitivity approaches 100% along with the specificity, and you see the other antibodies listed there have lower ranges. But again, keep in mind that it depends on the lab, the assay, and potentially the tech performing the procedure as to what your exact sensitivity and specificity is. Also keep in mind that celiac serologies can be falsely positive, especially with very low level antibody titers. And so I consider this to be less than 2 times upper limit of normal. So it can just be a transient finding. It's been noted to be elevated in cases of congestive heart failure, chronic liver disease, hyper IgG syndromes, and autoimmune diseases kind of broadly. If you have an IgA deficient individual, and so IgA should be tested in these individuals, and most of our screening order sets now have a total IgA as part of that initial screen. Then if they are IgA deficient, which is 5% of our population, you should look at the IgG antibodies, but they do have a lower sensitivity for diagnosing celiac disease. And also important to ask about an individual's diet when you're obtaining this test. So if your patient panel is anything like mine, half of my patients are already avoiding gluten just because they live in Colorado and they think it helps their GI symptoms. And so asking about how much gluten do they actually consume before you draw that lab is important. Currently, the recommendation is that individuals with positive celiac serologies who are 18 years or older should undergo diagnostic and confirmatory endoscopy. And endoscopy should include obtainment of duodenal biopsies, and we'll talk about the exact specifics related to those duodenal biopsies on the next slide. But what we're really looking for is histologic confirmation of the characteristic pathology findings, which are most broadly categorized using the Marsh classification scale, though there is a couple of newer classification scales that have been proposed and somewhat variably clinically implemented. The only exception for individuals who don't necessarily need an endoscopy and biopsies are those with a positive tissue transglutaminase and concurrent dermatitis herpetiformis. So if there's especially a biopsy diagnosis of dermatitis herpetiformis, that is so classically celiac and pathognomonic that you don't actually need to go in and get the biopsies, though it may be a good idea just to set a baseline for histologic monitoring, which we'll cover later in the talk. Also important is that seronegative celiac disease has an incidence of about 2%. So not very common, but it is an important consideration that if your diagnostic or your pretest probability or clinical suspicion is high enough, then it may be likely a good idea to proceed with endoscopy and biopsies. Where should we be biopsying for celiac disease when we do this upper endoscopy? So traditionally, we've talked about second portion of the duodenum being the key location of those biopsies, and that is still the mainstay and the most common location where we identify celiac changes. But I'd emphasize that it's important to take biopsies from the duodenal bulb as well. At least one, and more likely two, increases the diagnostic sensitivity of those biopsies, and that's been well shown that if you take more than 4 biopsies, it increases the likelihood of diagnosis. And then specifically in the bulb where you're looking, where you're biopsying. So a study actually looked and broke it down by 9 o'clock, 12 o'clock, 3 o'clock, and 6 o'clock. And at 9 o'clock and 12 o'clock was actually the more sensitive to pick up celiac disease. So grabbing from that 9 o'clock or 12 o'clock position or both is the location to look for in the bulb. Why that's important, why the bulb, and this is a recent publication from Gut, first description of what's been termed ultra short celiac disease, wherein the histologic pathologic changes of celiac disease histologically are only occurring in the duodenal bulb and not in the second portion of the duodenum. And there is some histologic changes in this ultra short celiac disease, which are illuminated there on the right, where in the second portion of the duodenum with this entity, you actually see normal villus height, slight increase in intraepithelial lymphocytes, but really it's that first portion of the duodenum where they're seeing the more classic Marsh lesions, such as complete villus atrophy, crypt hyperplasia, and intraepithelial lymphocytes. Why this entity is really important is because if you do a screen with serologies, it is more likely to have lower or undetectable elevated tissue transglutaminase or anti-endomesial. So if you're relying on that serology, you may be falsely led with this ultra short celiac. So again, it comes back to pretest probability, clinical suspicion, going in and grabbing those biopsies from the duodenal bulb. There's actually some expert opinion about when obtaining these biopsies, about separating jars and number of passes per biopsy. So if you're going in for a positive antibody, I will actually separate my bulb from my second portion. There is an expert opinion that perhaps taking one pass per one biopsy per forceps pass increases the likelihood of the pathologist having the correct orientation to make a confirmed diagnosis of celiac disease. Admittedly, I don't always do that in my practice, but it is out there as a potential recommendation. But remember that not all biopsies showing villus atrophy and or intraepithelial lymphocytosis are celiac disease. There are a lot of mimics, and I'm not going to read through this slide, but just keep in mind, especially when you're only seeing one characteristic, whether it's villus atrophy or intraepithelial lymphocytosis, that there are other entities out there, most commonly things like H. pylori, infection, SIBO, taking medications like NSAIDs, and sometimes other comorbidities can give you a false or a overlapping histologic mimic. Where I think celiac disease may be heading is this non-biopsy diagnostic strategy. This is really a movement in the field over the last 10 years or so, coming largely from Europe. But the most recent EPSCAN guideline recommendations for pediatric patients actually endorse a non-biopsy diagnostic strategy. And what is this non-biopsy diagnostic strategy? It's if you obtain a serum sample for serology and you have a tissue transglutaminase IgA that's greater than 10 times the upper limit of normal, along with a positive anti-endomysial antibody on a second separate blood draw, that is enough to make a diagnosis of celiac disease, and those children do not need an EGD with biopsies. But there's a lot of problems, a lot of unanswered questions when it comes to adopting that in the adult population. This needs strict protocol adherence. So if you're relying on making this diagnosis with a slightly elevated tissue transglutaminase, that may be inappropriate. We don't know how that affects the test characteristics. There's also, as I mentioned, this assay reliability between the two serology endpoints there. There's a lot of unanswered questions. So what's the optimal serologic cutoff for positive predictive value in adults? We see a lot of positive predictive variance by symptoms and other comorbidities that may influence the utility of this diagnostic strategy. And then what's the downstream effect of non-biopsy strategy? So if you tell somebody they likely have celiac disease based on serology alone, they now have to follow a lifelong gluten-free diet. And that has a lot of implications and costs to an individual patient. So what are those downstream implications? So currently for adult populations, it's not yet US guideline adopted or recommended unless an individual refuses to undergo an EGD or can't for a comorbidity reason or some other kind of contraindication. This was recently in Gastroenterology assessed through a systematic review, and in this systematic review, they looked at this non-biopsy diagnostic strategy being defined by greater than 10 times upper limit of normal of a TTG and a positive anti-endomysial, but it was in the same blood sample, so not necessarily a second blood draw. And this was in a very enriched population. So 62% of these people had known celiac disease proven on biopsy. And what they found is in the top right there that there's a 51% sensitivity and 100% specificity with a 98% positive predictive value using that non-biopsy diagnostic strategy. But what's really challenging is thinking about this positive predictive value, which is really reliant and impacted by incidence or prevalence of the disease at hand. So I mentioned early on that celiac disease in the general population has a prevalence of about 1.4%. But of course, if you're in a GI clinic, somebody has steatorrhea, iron deficiency anemia, and a first-degree family member, your prevalence or pretest probability may be slightly higher. So that may be a good strategy in that population. But if you're a PCP and you're seeing someone with bloating and no other symptoms and lab abnormalities, is that enough to make that diagnosis? So the ACG put out this diagnostic testing algorithm that if a person's eating a gluten-containing diet, obtaining serologies and total IgA is the proper screening protocol. If they're positive, then you proceed in adults with biopsy histologic confirmation. For individuals who the serology is negative, but your clinical suspicion is very high, then you can see down here, you still proceed with biopsy. And if you're finding histologic mimics or overlaps, then considering other entities as well. And if they're IgA deficient, again, looking at your IgG serologies and potentially pursuing biopsy for those individuals who are positive on those. However, if people are gluten-free, this is where that genetic test for HLA-DQ2 or DQ8 can be very helpful. If it's negative, essentially that person does not have celiac disease. So that can be a nice rule out test. But if it's positive, then you have to consider doing a gluten challenge, having them eat 3 grams of gluten per day for 2 weeks, then obtaining serologies, potentially considering biopsy in that population. Spoiler alert, updates in celiac disease, treatment is still lifelong gluten-free diet, and that has not changed. That is still the mainstay. A referral to a registered dietitian is mandatory upon making this diagnosis to really sit down and review in great detail, what does celiac look like? What does it mean in terms of implementation to our daily life? Symptomatic response with gluten-free diet, fortunately, is quite high, 80% in 2 months. Seroconversion happens, but it correlates poorly with actually histologic healing of celiac disease, what we consider mucosal healing in celiac disease, which takes a lot longer, on average 2 to 3 years, depending on the population, shorter with children, longer in adults. And in fact, many adults diagnosed in 50 years and older don't actually obtain histologic healing. But it's still an important consideration because that drives the risk of long-term complications, particularly the risk of lymphoproliferative disorders in the setting of celiac disease. So it's currently recommended not only to make this diagnosis, get them to a registered dietitian, but follow individuals with celiac disease over time, following serology, making sure serology is normalizing or close to normalizing, assessing for other comorbid conditions, nutritional deficiencies, ensuring gluten-free diet adherence and helping individuals who are struggling with that. And then down the road, typically about year 2 after making that diagnosis, going back with an endoscopy and repeating biopsies to assess for histologic healing. But it's important that these individuals need to stay in touch with a provider for quite a while, and it can't be a, hey, I made the diagnosis, eat less gluten, see you later. There's a lot of excitement about gluten detection devices. In the final couple of minutes, I'll just touch on kind of these hot topics. Gluten detection devices seem to actually perform pretty well when it comes to detecting gluten. But remember, the definition of gluten-free is 20 parts per million. And why that's important is because some of these new ones, especially the bottom right there, NEMA, which you take a little pea-sized piece of food, you put it in a couple of minutes, it spits out a yes, it has gluten, no, it doesn't have gluten, will actually pick up much lower concentrations of gluten, so it can give you a positive result when in fact the 20 parts per million may not be enough to actually cause toxicity in individuals with celiac disease. They also don't detect the fermented form of gluten, so that in soy sauce, barley malt, and containing products, so you can get a false negative in that setting. But a lot of interest in patient-driven discussion about that. Common question, are there any pills I can take for celiac disease? The answer is not yet. There's a lot of translational science and some clinical studies happening, and this is just a breakdown of kind of the pathology of celiac disease, and there are targets all along the pathway. But essentially, as I have recently reviewed, perhaps some of our industry partners may have key insights here, nothing on the immediate horizon when it comes to celiac disease treatment. So in summary, celiac disease is increasingly common and there can be heterogeneous presentations. We should be screening individuals with a IgA, tissue transglutaminase, as well as ensuring they don't have an IgA deficiency. Positive antibodies still in this day and age in adult individuals should prompt an EGD with biopsies, and those biopsies should include the second portion of the duodenum, at least 4 biopsies, and then the bulb. Whether or not you want to separate those in separate jars, I'll leave to you and your pretest probability. Not all villus atrophy or intraepithelial lymphocytosis is celiac disease, and keeping an open mind when seeing that histologic diagnosis. Fortunately, unfortunately, strict gluten-free diet is still the only current treatment for celiac disease, but it seems to be quite effective for controlling symptoms and allowing for histologic healing. But in keeping these people in your clinic, following them longitudinally about every 6 to 12 months, especially in the first couple of years until you obtain histologic healing, is an important clinical recommendation. There's a lot of new treatments in the pipeline, but none seem to be imminently on the horizon. So with that, thank you. Hopefully I did celiac disease justice today. Thanks.
Thank you, Dr. Click. You are truly an expert, well-rounded GI expert. So we'll kick off our panel discussion next. Please remember, ask questions, raise discussion points. We'll be utilizing poll everywhere, so grab your phones to participate. And I can bring the microphone to you if you have questions so that everybody can hear you as well. So I have to kick off, Dr. Patel, I have a question for you. Given the older study, with the general population data in aspirin, should we be telling all of our patients that we do colonoscopies that they should be taking an aspirin to decrease their risk of cancer?
A great question. So the current recommendations for the general population are not to recommend aspirin across the board for cancer risk reduction. The data is clearly there, but as you saw, it's a delayed benefit. So people have to take aspirin in the general population for 5 years consistently. And then 20 years down the line, they'll see a reduction in their cancer incidence and mortality. So for the general population, where we know other screening modalities are fairly effective and the risks of aspirin can be high as people age, bleeding, et cetera, it's not recommended across the board. But for our high-risk patients, our Lynch syndrome patients, I do have that conversation with all of them. And if they don't have a contraindication, I recommend aspirin.
Yep. We've got a question from Christy. Do you have a microphone or? Okay, that would be great.
Yeah, that's a great question. So I'll repeat it for the group. The question about Lynch syndrome was, is there a role for virtual colonoscopy or any other, if I were to expand non-invasive modality in between colonoscopies? Number one, probably to decrease the burden of invasive procedures, but also because we know the risk is high, whether there's other modalities that can complement colonoscopy. It's a really, really good question. There's none that are currently guideline supported, but there's a lot of research being done along those avenues. And one of the kind of areas that's breaking through actually was because of COVID and our severe restriction in colonoscopy capacity. In the UK, they essentially protocolized doing FIT testing, so fecal immunochemical testing in all Lynch syndrome patients, just because they weren't able to open their colonoscopy labs to help triage which patients needed a colonoscopy right away versus the ones that they could try to get to as soon as possible. And they found that actually FIT testing was able to kind of risk stratify patients fairly well. So there's ongoing clinical trials looking at stool-based markers, both FIT testing as well as, stool DNA, stool RNA markers, to see if that can kind of complement colonoscopy or sort of risk stratify patients who need more urgent colonoscopy. There have not been any studies yet in other non-invasive modalities like virtual colonoscopy or CT colonography. But, in South America, there's some studies on capsule colonoscopy because they don't have as much access to endoscopists, but the capsule colonoscopy can be administered remotely, read by an expert, and then, triage those patients to getting colonoscopy. So I think that's an area we didn't talk about today, but is evolving, and hopefully we'll have more complementary surveillance strategies in addition to colonoscopy over the coming years.
Dr. Cassell, I'm an internist at a state hospital, so I see a lot of gastroparesis from clozapine or psychiatric medications. They can't take Reglan because of TD already, and we're limited on our options. Do I need to prove for insurance purposes that they have failed the medication, or can I just refer them out to you guys for surgical options?
Right now, I don't know that we have anyone that's doing GPOM. That may change in the near future. Yeah, I think the question was from an internist who manages gastroparesis patients, for patients that are unable to take a lot of the medicines because they have pre-existing psychiatric illness and maybe another neuroleptics or high risk for PD. What is the avenue for referral for procedural options? So like I was saying, we don't, but then may change things to have someone currently does GPOM. We're happy to refer, we're happy to see all these patients in our clinic to discuss gastroparesis and other options. Like I said, domperidone doesn't appear to have, a lot of side effects that may be difficult interaction with other neuroleptics, maybe able precalcitride. Certainly we can do stuff like oxide and fluxum injection. I think most of us are comfortable doing that. So now just stay referred to us, and I'm happy to see them discuss other options.
It's a message for Dr. Jeff or question for Dr. Patel. What's your recommendation for small bowel screening in Lynch patients?
It's a good question. So the question was whether there's any recommendations for small bowel screening in Lynch syndrome. So the current standard of care is upper endoscopy with duodenoscopy. And usually with that procedure, I'll oftentimes use a pediatric colonoscope or an upper endoscope to at least get to D3, D4, and then colonoscopy with ileoscopy. And that's really just based on historical kind of small cohort studies that showed that the most common anatomic location for small bowel cancers in Lynch syndrome were in the upper bowel or the ileum. There's been studies to look at, capsule endoscopy or CT enterography, MR enterography for routine surveillance in Lynch syndrome. And unfortunately, they've been a bit disappointing. They've not shown detection of cancers earlier than patients just presenting with symptoms. And in those studies, the cancers that were diagnosed, a handful were actually missed by the capsule endoscopy that was done and found on upper endoscopy in the duodenum. So right now, we don't actually recommend standard kind of full small bowel visualization in Lynch syndrome. But we do recommend kind of other things that can clue us into whether we need to diagnose or do diagnostic testing of the small bowel. So for MLH1, MSH2 patients, after the age of 35, I recommend an annual CBC with iron studies. And if there's any trend towards iron deficiency, we'll do a small bowel evaluation and then counsel all of our patients about small bowel obstruction symptoms and have a very low threshold for evaluation in that setting. But routine screening with capsule is not currently recommended.
For Dr. Patel as well. Sorry if I missed this, but mechanistically, how does aspirin help with prevention of colorectal cancer prevention? And then second question essentially is, are there, I know like there's a delayed effect with aspirin in colorectal cancer incidents. Is there, have you subgroup analyses for like higher risk genetic carriers like MLH1, SH2, FPM for like aspirin use of colorectal cancer risk down the line?
Yeah. So Dr. Mindo, aspiring gastroenterologist, very keen questions. You didn't miss it because we don't know. We don't know how aspirin works in Lynch syndrome. The original thought was that it's COX-2 inhibition, just like other non-steroidals, but that would not necessarily explain this long-term sustained benefit. And so there's theories about how, so aspirin is from salicylate, which is a plant-based compound. And there's sort of this idea that salicylate is pro-apoptotic and essentially causes kind of programmed cell death or apoptosis of early abnormal progenitor cells in the colon, which then confer long-term protective benefit. There's also theories about how salicylate compounds modulate the microbiome and can confer long-term benefits, but these are all hypotheses, and maybe my colleague Cale Steiner in the lab has a little bit more insights on how to investigate these hypotheses, but we don't exactly know, how or why it works. And then in terms of subgroup analyses, I mentioned that this study, the CAP2 study, was designed in the 90s. We didn't even know PMS2 existed in the 90s. So the study mostly included MLH1, MSH2 patients, those high-risk genotypes. So when I counsel my patients that come in with PMS2 and have a lifetime colon cancer risk of 20%, I tell them aspirin reduces your risk of cancer by 50%, but that's a different discussion with an MSH2 or MLH1 patient who has a 60% risk, and we can decrease it to maybe 30%. For a PMS2 patient that's already at lower risk, 20%, I just advise them that we think there's still that relative benefit, but it goes from 20% to 10%. So then we really weigh the risks of aspirin, their other issues, their medical problems, and whether that, even though it's the same relative risk, whether that absolute risk reduction is worth it for them.
First question is regarding celiac disease. A patient of mine have incidental findings of lymphocytic biliaris. Patient was diagnosed Crohn's, have a surveillance of Crohn's and incidental findings of lymphocytic biliaris, but Crohn's was inflammation. EGD with the small bowel biopsy, duodenum and biopsy in the second and third duodenum that was negative. So what is your next step?
So the question was, an individual with pre-existing diagnosis of Crohn's disease with lymphocytic ileitis, is that right?
Yes.
And the duodenal biopsies on upper endoscopy were unremarkable. My suspicion is that that's related to the Crohn's disease rather than a coexisting separate diagnosis of some sort of enteritis undefined. And I would be chalking that up to the Crohn's disease and addressing my therapies and treatment plans accordingly.
Patient is already on the infection. Thank you. The next question is about gastroenteritis. And a patient who have severe gastroenteritis symptomatic weight loss, nausea, vomiting, referred for GPOM. During the procedure, it was found that the patient had pyloric stenosis. So where do you go from there?
I mean, it seems that they weren't able to manage that with the endoscopically. The pyloric stenosis was not endoscopically.
The pyloric stenosis was not diagnosed until at the time of the procedure. The procedure was done.
Yeah.
But 6 months later, patient had recurrence symptoms.
Yeah, I mean, I think, I didn't mention, surgical pyloromyotomy is an option for gastroparesis patients and seems to have similar efficacy to GPOM with more morbidity. And I think for a patient that had, pyloric stenosis, or maybe even any patient that failed GPOM, then it may be worth getting your surgeons involved for a surgical pyloromyotomy.
So you wouldn't recommend a repeat GPOM by surgical intervention?
Yeah, I think so. I mean, GPOM is an endoscopic procedure where they, tunnel through the antrum instead of, entering the peritoneum laparoscopically. If the operator who did the GPOM was fairly competent with a complete myotomy, then I would probably take the surgery. I'm not familiar about evidence on redo GPOM, but you maybe, could talk with the operator for that and see if they'd be willing to take another look. But that'd probably be a good discussion with that person and the surgeon if they're different people. So
I think my medical students were very smart in figuring this out. So I think the bottom line with this patient is her gastroparesis is possibly related to her obstruction from the pyloric stenosis.
Yeah.
And given a wrong diagnosis of severe gastroparesis, where in fact the patient have pyloric stenosis.
Yeah, and that may be, I think that pyloric flip is something that's very, very infrequent. We don't actually do it at either of our institutions where we have flip. But she may have been someone that if they had done that before her poem, that would have been more readily apparent.
What do you think, this is also regarding gastroparesis, what do you think of gastric pacemaker?
So again, just in interest of time, I didn't include that evidence. We don't do that here. I'm not super familiar. I'm not taking care of a lot of patients that have the gastric simulator. It seems to be most effective in patients with nausea predominant symptoms. And I think pacemaker is kind of a misnomer because it doesn't seem to actually improve gastric emptying. And then I think we get into this kind of murky area that's a lot of debate about the overlap between functional dyspepsia and gastroparesis and the actual correlation between gastric emptying and gastroparesis symptoms. And so here's a treatment that doesn't appear to improve emptying that affects some symptoms in some people, and maybe more through neuromodulation than improved emptying. I think the evidence is equivocal. I think less and less people are doing it, but I don't have a lot of extra input beyond that.
Swati, can I ask you a question? Hot off the press, colon cancer screening via blood-based assay. What are your thoughts in 30 seconds or less?
It does not replace the evidence-based measures that we have now. We know that stool-based testing via FIT testing or stool FIT fecal DNA, as well as colonoscopy, have very good sensitivity for detection of cancer. And of course, colonoscopy can prevent cancer. I think these blood-based tests are really exciting. And for individuals who just won't get screened, there might be a role of improving screening rates in that population, but they should not replace FIT testing or colonoscopy.
Well, thank you so much. Thank you to all of our speakers and our audience participation. This was an excellent first session. We're going to take a break, but there's a slight change to the agenda. We're going to be restarting at 9:50 sharp for our next session, high yield topics in hepatology and therapeutic gastroenterology. And please visit our photo booth by the elevators. We have amazing GI and hep props. You can tag RMH 2024 on socials, and we'll see you in 15 minutes. Thanks.
It's still uncomfortable. I'm like, please nobody ask me a hard question about.
Check 1, 2, 1, 2. Check 1, 2. Check. Hey. Hey. Check.
Test.
All right, everybody, we're going to start with session 2 as everyone rolls back in from the break outside. So as we kick off the next session, which is high-yield topics in hepatology and therapeutic gastroenterology, I just asked that all our speakers for this session make their way to the stage. I'll be kicking off the session, but Dr. Atwell and Colette, thanks for being here. We'll introduce you guys shortly. So thanks again. I think we've had a really great start to the day with some really fantastic talks, and we'll try to keep that up here with the next session. So I'll be kicking it off talking about updates in cholestatic liver disease, specifically PBC and PSC. I do want to just say again, thanks to everybody for coming today. It's nice to see a lot of familiar faces, and we've got people from all over. I know we even have some providers who drove up from New Mexico and some other surrounding states. So I'm kind of just looking out, and it's nice to see you. So again, my talk is updates in cholestatic liver disease, PBC and PSC. I have no disclosures for this talk. So we'll start with PBC, and PBC is going to be the majority of the content for this, especially because there have been some exciting updates in recent months. So PBC, it's a chronic cholestatic disease with a progressive course. It affects 1 in 1,000 females over the age of 40. And though it's typically thought to be a disease that predominantly affects women, it can affect men as well. And males actually tend to have a worse prognosis with this disease when they do have it. It's more common among siblings and in families where one member has been affected. And it's thought to be due to a combination of genetic predisposition as well as environmental triggers. There was actually a Scandinavian study showing that exposure to hair dye, manicures, frequent UTIs, and toxic waste dumps actually were associated with increased risk of PBC. It's a disease involving the small intrahepatic bile ducts, and though the pathophysiology is complex, ultimately a destruction of biliary epithelial cells leads to cholestasis and a buildup of toxic bile acids, which is the hallmark of the pathophysiology of this disease. We diagnose PBC based on these clinical criteria. The diagnosis is required with 2 out of these 3 criteria. So 1, biochemical evidence of cholestasis. That's mainly based on an elevated alkaline phosphatase level. 2, presence of antimitochondrial antibodies. These are highly specific to PBC and present in about 95% of patients with this condition. And then the 3rd criterion is histologic evidence of non-suppurative destructive cholangitis. So a liver biopsy is not required to make the diagnosis, as you can make this diagnosis if a patient has an elevated alkaline phosphatase and a positive antimitochondrial antibody. If one were to do a liver biopsy in these patients, you might see these classic findings such as a granuloma. And then on the right, you can see a florid duct lesion, which is basically a granuloma next to a bile duct with associated inflammatory cells. These are sort of textbook photos of what you might see in a patient with PBC. Pruritus or itching is really common. It's one of the most common symptoms that we have to manage in these patients. Prevalence of pruritus is reported as high as 70% and really maybe higher in what we see in our clinical practice. It's an itching that tends to be more intense late in the evening, worse in the soles of the feet and palms of the hands, and it's exacerbated by certain conditions, including pregnancy, heat, and contact with wool. Now, the etiology of PBC-associated pruritus is unknown. It's been attributed to a number of potential pruritogens. Bile acids themselves act as pruritogens. They induce mast cell degranulation. And then there are additional factors within the body, including endogenous endogenous opioids, as well as serotonin and other neuromodulators that modulate the perception of pruritus. There are algorithmic strategies that I would emphasize that are available for pruritus management and utilizing this in an attempt to alleviate patients' symptoms. General recommendations would be using skin moisturizers, topical agents, and even relaxation techniques, trying to train these patients to break the cycle of itching and scratching. First-line therapy for patients with PBC, certainly the first-line therapy for many years is ursodeoxycholic acid. I'll talk more about urso in a second. It's considered in this algorithm to be first line for itching as well, though in our clinical practice, we don't tend to associate urso as very effective in patients with itching per se. And so what we often go to next are bile acid sequestrants such as cholestyramine. Now, cholestyramine and other bile acid sequestrants spaced apart from urso and other medications for at least 4 hours. And so sometimes the timing and dosing of that medication can affect its use. Second line medication is rifampin. Third line and fourth line include oral opioid antagonists such as naltrexone, and even selective serotonin reuptake inhibitors or SSRIs such as sertraline at the 100 milligram dose are shown to be effective in treating pruritus in many patients. After that, we're getting to fifth line options such as phenobarbital, plasmapheresis. I've seen one patient require plasmapheresis ongoing for PBC treatment. Phototherapy is used, but really by the time you're getting to those fifth line treatments and patients with refractory pruritus, really should be thinking about liver transplantation as a potential option for those patients. Many patients with PBC also suffer from cholestasis and other complications that are related to cirrhosis. So because of cholestasis and vitamin D deficiency, fat-soluble vitamin deficiency, they are at increased risk for osteoporosis. And in addition to hyperlipidemia, certainly if they develop cirrhosis, there are risks of complications associated with portal hypertension, such as varices. And then there's a risk of developing hepatocellular carcinoma. A substantial number of patients with PBC progress to liver failure, transplant, or death within 10 years of diagnosis. So this is a progressive disease in many patients. So I mentioned ursodeoxycholic acid earlier, ursodiol. It's the backbone of therapy in PBC. It has been for 2 decades. It's an orally administered non-toxic bile acid given at the dose of 13 to 15 milligrams per kilogram per day. So it's weight-based split dosing. Urso replaces the bile acids that are normally produced by the liver, which are more toxic and can harm the liver. And we know that early treatment provides the most benefit. Greater response rate tends to be seen in patients without cirrhosis. And we typically see an improvement in liver tests within a few weeks of starting therapy, and 90% of the improvement actually occurs within the first 6 to 9 months. It's considered a safe medication, certainly may improve clinical symptoms, and it's been shown to not only improve quality of life and symptoms, but delay progression of disease and improve survival as well. This is data from the Global PBC Study Group showing that alkaline phosphatase and bilirubin after 1 year of follow-up had a long linear relationship with the occurrence of clinical outcomes of liver transplant and death. You can see in the green line that responders to ursodiol had improved cumulative liver transplant-free survival as time progresses on the x-axis with treatment of ursodiol compared to non-responders. We talk a lot about the treatment goal, not only in clinical improvement in symptoms, but in reduction of the alkaline phosphatase. But there's data that suggests that aiming for a bilirubin less than 0.6 of the upper limit of normal would be an appropriate goal as well, as we know that the bilirubin greater than 0.6 of the upper limit of normal, and this data was associated with increased risk for liver transplant or death at 10 or 15 years compared to a lower bilirubin. Now, despite all of that, and the fact that this medication has been around for a long time and has been the backbone of therapy, about 40% of patients do not respond to ursodeoxycholic acid, and about 3 to 5% don't tolerate the medication. Some side effects to this include GI side effects, bloating, diarrhea, thinning hair in some patients as well. And so this led to a lot of translational research and development of new medications, which are ongoing, and I'm going to get to the more recent developments shortly. But obeticholic acid or Ocaliva became the next medication approved for the treatment of PBC. This is a modified bile acid and FXR agonist. And essentially by affecting the FXR binding site inside the cell and then reducing transcription of inflammatory mediators, such as, for example, TNF alpha, interferon gamma, this leads to decreased inflammation. We have decreased activation of stellate cells and therefore decreased fibrinogenesis. And in addition, decreased bile acid synthesis as well. So this is happening at a transcription level. And with decreased bile acid synthesis, you have certainly decreased bile acid uptake, and you're targeting the homeostasis of the pathophysiologic hallmark of this disease, the accumulation of toxic bile acids. This is the POISE study. It was published in the New England Journal of Medicine in 2016, looking at obeticholic acid at the 5 and 10 milligram doses compared to placebo, with a primary endpoint of a reduction in the alkaline phosphatase or bilirubin, and essentially showing that in the double-blind phase as well as the open-label phase, a significant patient response for obeticholic acid compared to placebo. The issue with obeticholic acid, as many of us know from our practice, is that pruritus worsens in a substantial number of these patients. So actually about 70% of the patients in this New England Journal study had worsening of pruritus on obeticholic acid, which isn't great because a lot of these patients are itching to begin with, as we've already established. Still, though, long-term obeticholic acid treatment in the patients who can tolerate it is associated with reversal and stabilization of fibrosis. About 50% of patients had reversal of fibrosis at 5 years with treatment of obeticholic acid. And on the right in the graphs, you can see that long-term obeticholic acid had higher long-term survival as well. As obeticholic acid started to be used in clinical practice, it was noticed that certain patients, especially those with clinically significant portal hypertension and decompensated cirrhosis, did worse with the medication. There were reports actually of patients dying, increased rates of death on obeticholic acid, and that led to a black box warning. So in the United States, obeticholic acid is not approved. It's contraindicated for patients with clinically significant portal hypertension or decompensated cirrhosis. It is worth noting that in the European guidelines, it's not contraindicated for those populations, but instead they recommend a dose reduction. So now the newer medications and more exciting updates, perhaps, given what's happened just in the year 2024 alone. So elafibranor, recently approved medication. And now we have a third option for the treatment of PBC as far as FDA-approved medications. So it's an oral dual PPAR alpha delta agonist. And in a phase 2 trial, which we'll talk about a little bit, this medication has been shown to improve biochemical markers of cholestasis, also improve symptoms of pruritus, and was well tolerated. It also works at the transcription regulation level by increasing bile acid elimination, decreasing bile acid production, and reducing inflammation. This is the ELATIVE study. This was published not long ago. This aimed to evaluate the efficacy and safety of elafibranor in adult patients with PBC, in patients specifically who had had an inadequate response to URSO or were intolerant to URSO. And so patients meeting that criteria were randomized to either oral elafibranor at the dose of 80 milligrams a day or placebo. And then there was an open label extension in this study as well. And treatment with elafibranor was associated with significant improvement in biochemical response at week 52. So at 1 year, you can see in the dark blue, patients with biochemical response, 51% in the elafibranor group compared to 4% on placebo. And in fact, only patients receiving elafibranor achieved normalization of the alkaline phosphatase at week 52. So none of the patients on placebo received that target. The reductions in the alkaline phosphatase were observed as early as week 4 of therapy and sustained through week 52. And so you can see the placebo in the gray line and elafibranor in the dark blue. That reduction basically in the alkaline phosphatase persists over time. There was also a trend for improvement in a subjective itch score modality that was looked at. It did not reach statistical significance through week 52, but you can see this trend in the dark blue compared to the gray placebo in improvement in itching, and so potentially an improvement, at least in many patients with itching. It was generally well tolerated, so the most common adverse effects were abdominal pain, diarrhea, nausea, and vomiting. And like I said, this was published as well in this regional journal from the Northeast in last year and reached FDA approval in June of 2024. So just 2 months ago. Now at the EASL conference in Europe just earlier this summer, elafibranor, they presented the data from the open label extension essentially from the ELATIVE study, so extending from week 52 to week 78, and essentially showed that the composite biochemical response that they looked at in this study, including alkaline phosphatase normalization, persisted through week 78 with elafibranor compared to placebo. So this medication is now FDA approved for the treatment of PBC as a combination with ursodeoxycholic acid in patients who are inadequate responders to urso, or as monotherapy in patients intolerant of urso. And the dose is 80 milligrams a day. It can be taken with or without food. Some warnings or precautions from what we know about this new medication so far. It has been shown to increase risk of myalgias, fractures, and there have been some cases of drug-induced liver injury and hypersensitivity reactions. These are really rare, but reported. It's not recommended in patients with decompensated cirrhosis, and we recommend avoiding this in patients with biliary obstruction or pregnancy. It's also a weak CYP3/4A inhibitor, and so that's just something to keep in mind as you think about drug-drug interactions. Now, in terms of PBC in general, long-term management of patients with PBC, in addition to trying to improve their pruritus and reverse the disease course with these medications we've talked about, include monitoring for complications. So we talked about looking, for example, for vitamin deficiencies. We recommend a DEXA scan or bone mineral dense scan at the time of diagnosis and then every 2 to 4 years. And then patients should also receive an upper endoscopy every 1 to 3 years if they're cirrhotic, or if they have a Mayo risk score that's elevated. That's a risk score that essentially quantifies their risk of portal hypertension in the setting of PBC, as non-cirrhotic portal hypertension is possible in those patients. And then in patients with cirrhosis, just like any patient with cirrhosis, we screen them for hepatocellular carcinoma with ultrasounds plus minus AFP based on the AASLD guidelines every 6 months. So we talked a little bit about the pathophysiology of PBC, but it's been an exciting field because there are multiple potential targets that may decrease bile acid synthesis, that increase detoxification of these bile acids, that reduce inflammation, that pharmaceutical companies have targeted. We talked about in the bottom left the elafibranor, but another PPA agonist that I do just want to mention is seladelpar. It's likely to become FDA approved within the next month. I heard potentially next Wednesday. This is a once daily PPR delta agonist that has shown great efficacy in similar endpoints and also improving pruritus. And so more to come of that. You'll probably see that in the news next week, depending on your news source, I guess. Bezafibrate is a pan-PPAR agonist. This is also a lipid-lowering agent as a fibrate, as you might imagine. Not available in the United States, but has been shown to improve treatment of PBC. This was a placebo-controlled trial published in the New England Journal way back in 2018, looking at bezafibrate for the treatment of PBC. And bezafibrate was shown to improve markers of cholestatic injury in these patients compared to placebo. That was the study, bezafibrate versus placebo. There's also a study published 3 years ago looking at fibrates for itching in fibrosing cholangiopathies in general. So this actually included patients with PBC and PSC, which we'll talk about in a second, primary sclerosing cholangitis, and did show an improvement in itching in the patients on bezafibrate compared to placebo. If you just look at the patients with PBC, this is a small sample size, so you can see 11 patients in the bezafibrate group, 15 patients in the placebo group, but there was a difference in improvement in itching. Safety considerations for fibrates. Well, the use of fibrates can result in an increased creatinine. This does appear to be a class effect. It's not always associated with a decreased GFR, and it is thought to be reversible, but we do watch for this. And there have been some reports of liver toxicity from fibrates as well. Now, there's also a study, an ongoing study, looking at the combination of obeticholic acid and bezafibrate. And this is a phase 2 double-blind randomized study looking at this. And actually, the University of Colorado, our group is a participant in this study. So looking at basically serum markers of PBC, some metabolic safety outcomes, and safety in general. So some initial data from this was published or presented rather at EASL, which is the European meeting earlier this summer, looking at the month 6 data for this study. And so looked at basically a trend towards alkaline phosphatase normalization at month 6 and biochemical remission with this combination. So more to come in perhaps next year's meeting. So again, the majority of the talk so far has been on PBC. I want to spend just the remaining few minutes talking about PSC, primary sclerosing cholangitis. Now, the last AASLD guidelines for this were published back in 2022. I've highlighted Lisa Foreman on there. Many of you know Dr. Foreman is a professor of medicine in our section of hepatology. She's a mentor of mine and certainly a national expert in cholestatic liver disease and autoimmune liver disease for that matter. And so she was an author on these guidelines. You might be wondering why she's not giving this talk instead of me, but she's on vacation, so you're stuck with me. Pathogenesis of this is complex, certainly, and we have a lower understanding of the pathogenesis of PSC compared to PBC. There are so many interplaying factors here that it sort of shows why it's hard to find a medication that treats PSC and why there is no FDA-approved medication for PSC. But we know that there's some dysregulation in the gut. As many of you know, majority of patients with PSC also have inflammatory bowel disease. This gut dysregulation leads to immune activation and response therein. And then biliary responses and myofibroblast activation next to the bile ducts leads to the pathophysiology of this disease. So it's a cholestatic liver disease, just like PBC. So there's elevated alkaline phosphatase. Autoantibodies can be present in these patients. We do always, like in any other case, recommend excluding other liver diseases and secondary causes of sclerosing cholangitis. But this is a stricturing disease, unlike PBC. And the hallmark of this disease are the discovery of strictures on some form of a cholangiogram, either an MRI or an ERCP. So although ERCP was traditionally the gold standard, it is a procedure associated with risks, certainly, but our most recent data shows that a high-quality MRCP should have sensitivity and specificity comparable to ERCP, and a strategy of MRCP followed by selective ERCP has been shown to be cost-effective in these patients. And so oftentimes we start with an MRI to identify these biliary strictures. And in terms of imaging, the hallmark, like I said, are the biliary strictures. You might remember the sort of buzzword in your training or school of the classic beads on a string appearance, showing these strictures in the bile ducts. Now, the beads are contrast in the bile ducts, and the intervening dark areas are the strictures, the hallmark of this disease. Now, a liver biopsy is not necessary to diagnose PSC, and really we would only get a liver biopsy if the diagnosis was unclear, or if we were concerned for overlap with another syndrome such as autoimmune hepatitis, or if we thought that these patients had small duct PSC, which I'll talk about in a second. But you can see that this concentric fibrosis surrounding a bile duct that resembles an onion ring. And so this is the classic onion ring appearance of the bile ducts with PSC. Fatigue, pruritus, and jaundice are common symptoms. This is associated with impaired quality of life, and many patients have these symptoms at the time of diagnosis. The natural history is that this is a progressive disease with a highly variable course. You can see on the right that in both, in both the population-based cohort as well as a liver transplant center cohort, so again, more of a selective group, over time, since diagnosis, these patients have decreased survival. So you can see from 100% survival at the time of diagnosis, of course, down to about 20% at 30 years since diagnosis. So spontaneous resolution of PSC does not occur, and it's actually not even improved by colectomy for ulcerative colitis, despite the pathophysiology that we talked about. Small duct PSC is a small percentage of patients with this condition. About 5% of PSC is small duct PSC. This is a case of basically patients who have a normal cholangiogram, so no obvious strictures on MRI or ERCP, but they have a biopsy showing, for example, that onion skin lesion. We think that there's about a 25% risk of patients with small duct PSC progressing to classic PSC over 5 to 14 years. Interestingly, these patients tend to have a lower risk of cholangiocarcinoma and overall improved survival compared to classic PSC or large duct PSC, as you can see on the right. And there's debate as to whether this is really a separate entity or really just an early or mild form of PSC itself. Now, the treatment of PSC, I don't really have a lot of slides on this like I did with PBC because there is no proven pharmacotherapy for the treatment of PSC. Treatment is directed at complications and symptoms if and when they occur. And like I said, therapy of IBD actually has little effect on PSC course and vice versa. We spend a lot of our time with PSC monitoring for malignancies and looking for potential indications for liver transplant. Certainly, because there's no approved pharmacotherapy, this highlights the need for clinical trials and involvement. And I know that many of you here are to have patients with PSC, whether at an academic center or in the community. And I think if patients are interested, you should really explore the possibility of a clinical trial. And we often have those ongoing at the university here. Bile duct cancer or cholangiocarcinoma is the most common malignancy that occurs in patients with PSC. It can occur at any time, although many patients are diagnosed within the first 2 years of diagnosis. About a 10 to 20% lifetime risk of cholangiocarcinoma in patients with PSC, and it's actually the #1 cause of death in patients with PSC as well. They're also at increased risk for colon cancer, pancreatic cancer, hepatocellular carcinoma, and gallbladder cancer. And you can see here the cumulative incidence of cholangiocarcinoma over time, rising in the first 2 years, especially since diagnosis, and then slowly increasing from there. Though screening is actually ineffective, if you really look at the data, expert guidelines do recommend annual MRI as well as a CA19-9 tumor marker to screen for patients, screen our patients to look for signs of cholangiocarcinoma, which can include new or worsening strictures on cholangiogram. And then, though this is really outside the scope of today's talk and the time that I have, we do consider liver transplantation for a select few patients who meet very specific criteria for cholangiocarcinoma. This is really a dramatic graph showing just the increase in colon cancer, colorectal cancer in patients with PSC combined with chronic ulcerative colitis compared to chronic ulcerative colitis alone. So you can see at 10, 20, and 25 years, their incidence in the light gray of colon cancer with ulcerative colitis, and then you add PSC on top, you can just see the dramatic increased risk. So 50% of patients, 25 years of PSC have a risk of colon cancer compared to ulcerative colitis alone. It's really striking. And then other disease-related complications include infection, especially cholangitis, cirrhosis, certainly. And then similar to PBC, these patients are increased risk for bone disease, high cholesterol, fat-soluble vitamin deficiency, and malabsorption. So PSC management, the surveillance expert opinion, imaging every 6 to 12 months for both cholangiocarcinoma and HCC, a serum CA19-9 every 6 to 12 months, a cholecystectomy because of the risk of gallbladder cancer if someone has a gallbladder polyp over 8 millimeters, and annual colonoscopy if the patients have concomitant IBD, which the majority of patients do. We also screen for fat-soluble vitamin deficiencies, treat lipids, baseline DEXA scan, and like I said, an annual colonoscopy if they have, it says ulcerative colitis, but really any form of inflammatory bowel disease would be appropriate to say. Skip the last 2 slides for the sake of time and go to the summary. So to summarize what we talked about, PBC is an autoimmune cholestatic liver disease. It results from genetic factors and environmental triggers, progresses slowly. We talked about biomarkers and current therapies, and now the emergence of new therapies as well, including elafibranor, and more to come, like I said, this month. PSC, on the other hand, has no established therapy. we didn't talk about this much, but response to ursodeoxycholic acid establishes prognosis, but we avoid high dose urso in patients with PSC. Clinical trials and liver transplant are important considerations. And the most important thing that we do really for these patients in practice, other than monitoring their complications, is surveillance for malignancies. I do want to thank Dr. Foreman for sharing some of the slides that I presented today, and thank you all for your attention. Really appreciate it. Okay, moving right along, Dr. Atwell is a professor of medicine in our section, advanced endoscopist, and I've had the opportunity to work with Dr. Atwell for many years now as well. So thanks, Gus, for being here today to give us your talk on the updates and management of pancreatic cysts.
Thank you. Yep. Thanks, Ivash. Thank you, Debbie. Thank you, Kelly, for inviting me to talk today. I've seen the breakdown of the audience, and I'm going to try to make this relatively practical, case-based talk so that everybody can walk home with some pearls about pancreatic cysts. And I will give you some up-to-date science as well, but just want to make sure everybody learns something that'll affect their practice. So pancreatic cysts, oh, and I'm on call, so let me start my timer and also keep this around in case Taylor Carl gives me an urgent text. So cysts are getting more common, unfortunately. Unfortunately for us, because it's adding to a burden of diagnosis and also a financial burden. And why? Because we're imaging patients more. As you know, anybody goes into the ER with back pain or belly pain gets a CT scan, and also imaging is just getting a lot better. And so cysts are found quite frequently, anywhere from 2 to 16% of all comers, and this prevalence increases even more when you're talking about patients over age 60. And this is just the typical, hopefully you can see, oh darn, you can't see my, what did you use, a laser pointer? Is this, let's see, which one is the little, I see 5 buttons, none of which look like a, oh, is it, oh, really? Oh, that's my, okay, that's my, thanks, the green button. All right, I'll try both. Thanks, Jay. So this is just a typical little incidentally found IPMN of the side branch that you see on a routine CT that'll prompt a referral to our clinic. Not doing anything obstructive, not associated with pancreatitis, just sitting there relatively innocently and causing a little bit of a dilemma for us and the anxiety for the patient. So the prevalence, like I said, goes up with age. So up to 40% of patients that undergo MRI of the abdomen for other indications, back pain, belly pain, whatever, will have a pancreatic cyst. About 20% of patients in their 50s. So that's a lot of cysts. And that's basically the problem. The patients think they're going to get cancer. We have to reassure most of the time they're not. But the volume is really just the main issue that we have to deal with. So only about 2.5% of all these referrals of incidental cysts are eventually going to have dysplasia or cancer or need surgery. That's a huge burden of unnecessary anxiety, in my opinion. But we also can't forget about the risk, and I'll talk more about why we take these seriously in just a second. But just also looking at surgical data, pancreatic cysts are more common in the operating room as well. If you just look at one center, the number of pancreatic surgeries are going up, and also the size of pancreatic cysts going to the OR is going down. So we're no longer like 30 years ago taking patients with symptomatic large pseudocysts or mucinous adenomas to the operating room. Still some of those patients are going, but we're largely seeing patients with IPMNs that are small, asymptomatic, and probably going to be benign forever going to the operating room. And they're adding to the problem of unnecessary cost and risk. So 30 years ago, most patients going to the OR were symptomatic. About 15 years ago, it was down to 35%. It's about 20% now. So why is this significant? Why do we take them so seriously? Because they do increase the risk of cancer. Okay, we can't just say, cysts are benign, it's not a problem, because even if it's a 1.5 centimeter IPMN, there's a relative risk of cancer over 6, more like 10, a relative risk of 10 in all patients. Again, the relative risk overall is small, but the absolute risk is also very small, but excuse me, I don't want to say that. The relative risk is high, but the absolute risk remains very small. So they can get cancer in the cyst. That's mostly what we look for with surveillance imaging, but they can also have cancer develop outside the cyst. There's an increased risk of pancreatic cancer away from the cyst in these patients with cysts. So many reasons to take these seriously. And if you look back at Barrett's esophagus management 20 years ago, before we had radiofrequency ablation, it's a very similar problem. We have a common problem. Asymptomatic, 1% of the time it'll lead to cancer, but it's also a cancer that's very hard to treat and often fatal if diagnosed too late. But we have a treatment, at least before ablation, that was very risky, right? Esophagectomy. So that's kind of where we are now in 2024 with pancreatic cysts. Common problem, relative low risk overall, but we don't have a really safe, easy treatment that patients are willing to accept yet. We're hoping that by the end of the talk, I'll convince you that we have some other options available. So when we see a referral for pancreatic cysts, and this is kind of my bread and butter in clinic, first thing we need to decide, just looking at the imaging, talking to the patient, is it something we need to worry about? Is it something the patient needs to worry about? So this is, I'm going to have like 5 or 6 real cases from my clinic. This is a case from 2 months ago at Denver Health, a patient that had recurrent UTIs. They got imaged by her PCP or his PCP because of that, and the CT showed an incidental pancreatic cyst. But this patient was chronically very ill, morbidly obese, on oxygen, basically was bedbound or couch bound in his house, and not able to really live, so to speak. And the patient was sent to my clinic, they got an MRI before I saw the patient, and clearly you can see this little side branch IPMN in the neck of the pancreas communicating with the duct. You can see the communication a little bit better there. There were also a couple of cysts out in the tail. But I can't say this patient, tell this patient, so what? They take them seriously. This patient's anxious. We have to reassure them that this cyst, though real and though associated with a small risk of cancer, is not going to affect this patient's lifetime. He's too old. He's too chronically ill. Something in the heart or lungs is going to get this patient before pancreatic cancer. So this is a cyst I wouldn't even image any further. And I would say tell the patient, quite frankly, not to worry about it. Sometimes that can be difficult, though, because by the time they come see me, they're quite frankly obsessed with it. Or highly concerned. Colette's laughing because she knows the patients I'm talking about. So the step 2 that comes into play when we evaluate cysts is trying to stratify them. Just on cross-sectional imaging, is this something that's obviously going to go to surgery, or is this something that's obviously going to be either dismissed or just sent to surveillance imaging right away? And so sometimes we can actually determine this just looking at a CT scan. So mucinous cysts, MCNs, IPMNs, we care about because there's a cancer risk. The non-mucinous cysts, the pseudocysts, and the serous adenomas, we don't care. We don't send to surgery, and we actually don't even follow them up on further imaging. So we want to be able to rule out a pseudocyst. So when should you think about a pseudocyst? Well, if the cyst wasn't there on prior imaging, if the patient has a history of pancreatitis, either acute or chronic, if they have necrotic debris within the cyst, or if there's a clear episode of prior pancreatitis, which is in the history and it's been confirmed by labs. Sometimes that can be hard to tease out, especially since cysts themselves can cause pancreatitis rather than pancreatitis leading to the cause of a pseudocyst. But pseudocysts, if you can identify them and diagnose them with confidence, it's great because they don't need to be followed. They don't need to be drained unless they're very large or compressing the bile duct or compressing the stomach, or they're infected. And that's a small minority of pseudocysts. So this is just an example of a patient who sent to me for chronic pain, alcoholism, and a pancreatic cyst. It turns out this was necrotizing pancreatitis the patient had been having at home, but clearly you can see normal pancreas here, necrosis in the body, fluid weeping off the side of the pancreas, and this real a little bit of necrotic pancreas out here in the tail. And basically, it had been misdiagnosed as a pancreatic cyst, but this patient with necrotizing pancreatitis needed nothing more than a cessation of alcohol and conservative treatment. And that's another example of a pancreatitis-related cyst. Chronic calcific pancreatitis with an obstructive stone in the head, large cyst out in the body and tail. Could this be a MCN or an IPMN? Sure, could be, but statistically, it's much more likely to be a chronic pseudocyst. So this patient would need management of the pancreatic stones and repeat imaging in 3 months, and most likely this thing will either go away or it'll be 3 times smaller, thereby making a diagnosis of a pseudocyst. So I'm not going to go through this table because hopefully some of you have seen it. The fellows, I'm sure, put it in their attic, the attic of their brain from first year fellowship or from residency, but there are some take-home pearls when you look at a breakdown of the types of pancreatic cysts. Serous adenomas, microcystic, sometimes they'll have a central calcification or scar. If you see that, you're done, you have a diagnosis. MCNs or mucinous cystic neoplasia, these only occur in females, they only occur in the body and tail. Like 1% will be in men or in the head of the pancreas. And solid pseudopapillary tumors are often large, symptomatic, young females, often hemorrhagic or causing a lot of pain. and cystic neuroendocrine tumors, also solid and cystic, and often causing symptoms as well, either hormonal or just pain. Both of these two I've highlighted in red because you can make a diagnosis very easily with a fine needle aspirate. They're very good cytology. These others, not so much, even though if you have a cytology that's suggestive, it's highly specific, but the problem is we just don't get sales when we aspirate most pancreatic cysts, including these three. These are the ones we love to see because we can always diagnose them with an FNA. What about main duct IPMN? This is another kind of far into the spectrum pancreatic cyst that is clearly going to require an intervention. These patients go straight to surgery. This is the only slide I'm going to really mention about main duct IPMN because these are usually not subtle cases. These are associated with marked diffuse or partial dilation of the main pancreatic duct. You can often diagnose them just on simple EGD, looking at the ampulla. About 30% of the time, you'll see mucin packed in the orifice. And again, large duct, massive ducts, over 10 millimeters most of the time. They can occur anywhere in the pancreas. They can affect females and males. And the diagnosis is relatively simple just because the degree of dilation of the pancreatic duct without another cause, such as a tumor or stone, and also because doing an ERCP and a biopsy of the duct, or just a simple FNA during EUS of a cystic component of the cyst will show you this classic papillary frond that you can see either endoscopically or histologically. It looks like a lot like a routine colonic polyp. That's IPMN. If you can make a diagnosis by imaging or by EGD or by ERCP or EUS, you're done. The patient needs to go to surgery, assuming they're well enough to tolerate the surgery because it will be a pancreatic resection. Serous cystadenoma, I'm going to go back to this because you can often make a diagnosis just on cross-sectional imaging. These are mostly females. They're microcystic, okay? That are honeycomb or pomegranate looking. If you're lucky, you'll have a central calcification or scar. Like I said, only about 20 to 30% have that. But if you do see that, diagnosis is made. These are sometimes symptomatic, usually not. The cytology, if you perform FNA, you can often get a positive cytologic diagnosis by showing cuboidal epithelium. Problem is it's only about 20 to 30% sensitive. So usually an FNA is not diagnostic. We do have a mutation that we can check in the pancreatic cyst fluid. The von Hippel-Lindau mutation is highly specific. The only problem is it's expensive and it's not readily available. So these are another cyst type, which are great to diagnose because the management is relatively straightforward. This patient, if you make the diagnosis with clarity, can be followed without any, just return to me if you have abdominal pain or new symptoms. Otherwise, you don't need surveillance imaging and you don't need surgery unless they're very large or causing symptoms. This is just what it looks like on EUS. This is the microcystic component of the lesion. This is the macrocystic or large cavity component. Again, you love to see that because you see that on EUS, you basically have a diagnosis. Don't need to send these patients to the surgeon unless they're massive tumors, cystic tumors. Another case from the Denver Health Archives, a real case. A few years back, a patient came in with epigastric pain, Denver Health patient, alcohol, smoking. You're probably thinking this is acute pancreatitis. We did too. Serum lipase was elevated, MCV was elevated. The patient had a CT scan showing this, which is a basically normal looking pancreas, head, neck, body, but this well-circumscribed cystic lesion out in the tail of the pancreas with an otherwise normal looking pancreas in the setting of presumed pancreatitis. Well, hopefully you were thinking what I was, this is just a routine alcoholic pancreatitis with pseudocysts, common things being common. We were too, because the patient had persistent pain over the next couple of weeks. We ended up doing an EUS FNA and it just showed brown turbid fluid with acute and chronic inflammation, also consistent with the pseudocysts, a very high elevated fluid amylase, also consistent with the pseudocysts, an indeterminate CEA and scant mucin, which we thought was probably contaminant from the stomach, all consistent with pseudocysts, right? So the patient kept having pain. Repeat CT scan showed this was not going away. And if you look really carefully, you can see some septations developing within the middle of the lesion. And because of the morphologic changes and because of the fact the patient's pain was persisting, and this was before we had EUS guided biopsy at Denver Health, the patient went to the OR and had a surgical biopsy. And that showed this. I'll go back to the gross findings in a second. This is the classic ovarian stroma of a mucinous cystic neoplasm, overlying mucin in the lumen and overlying columnar epithelium with a very cellular stroma, just like you would see in the ovary. This is a mucinous cystic neoplasm. If I'm repeating some of the cyst types and findings, it's for a reason. This is classic board questions. So this is what it looked like grossly. This is what it looked like with the spleen off to the side on surgical resection. And this patient was cured. Pain went away too, by the way. So what about mucin assisting neoplasia? Remember, only females, only in the body and tail. These are always going to be macrocystic. So they're not going to be honeycomb or pomegranate. They're going to have large chambers. If you're lucky and you see a peripheral calcification like you see here, that's diagnostic. It's kind of like the central scar of the serous cyst adenoma. You're lucky if you see it. It makes a diagnosis, but you usually don't see it, unfortunately. So we're left to determine a diagnosis by other means, such as biopsies, fine needle aspiration, et cetera. Like a serous cyst adenoma, the cytology is diagnostic. The problem is it's not very sensitive. So we miss it by, we miss cytology on these lesions when we FNA them about 80% of the time. When we find these lesions, they need to go to the surgeon because usually the surgical resection is a relatively low risk procedure. It's a distal pancreatectomy as opposed to a Whipple, which is a much bigger deal. And these patients are cured after surgery. They don't have to have the rest of the pancreas surveyed, et cetera. So these patients, I'm not going to go into why. There's new data shows that the small ones can actually be followed pretty safely. If they're less than 2.5 centimeters, the risk of progression or growth or cancer is 1%. 1 to 2%. So patients can be offered observation if they're small. The problem is most of these are 3, 4, 5 centimeters or bigger. So they're almost always going to go to the operating room. I got to start moving. Sorry. Another case, a lady, 17-year-old lady who had severe epigastric pain about an hour after she got bumped during a soccer game, came in and got the CT scan in the ER, a large semi-solid, semi-fluid hemorrhagic lesion in the head of the pancreas, basically replacing the head of the pancreas, for which an FNA was performed, showing these large, very cellular sheets of basically monomorphic small round cells that you can see here on high power, for which the immunohistochemical staining was positive for CD56 and CD10, but negative for synaptophysin or chromogranin. So not a neuroendocrine tumor. This is a solid pseudopapillary tumor. Okay, this is a classic solid pseudopapillary tumor. Young female, symptoms, pain, it hemorrhaged within the lesion. She's only, I think, 20 years old. These patients need to go to the operating room, not only because of the risk of complications, bleeding, pain, et cetera, but mostly because the risk of cancer is about 10 to 20% lifetime. So those are the fun cases. Those are the ones we love to get because the diagnosis is relatively easy. The treatment's usually relatively straightforward, either operating room or nothing, right? Unfortunately, 75% of the referrals I get are not that. They're going to be the IPMNs of the side branch that we basically have to care about and have to follow, but usually will not operate on. So IPMNs of the side branch are common. They're usually asymptomatic. They can occur anywhere in the pancreas, but more commonly in the head. They either look typically like a cluster of grapes or a clover, and they tend to sit there and do nothing and maybe grow a little bit, 10% over 10 years or so, and have a cancer risk, which most patients will accept and live with and get followed closely with surveillance imaging. So how do imaging studies help us? CT and MRI are both good. They both pick up cysts. They're fairly poor at making a diagnosis of cyst subtype. So about 25% of the time a CT and MRI will not tell us what type of cyst it is, and we have to go snooping a little bit more. CT is better for looking at the wall of the cyst and calcifications if they're there. MRI is much better at looking at the duct if there's communication, and also for a mural nodule if present. Both studies, by the way, I should say, are very poor at classifying cysts when the cysts are very small. What about EUS? This is something obviously we perform relatively commonly, particularly when cysts are over 3 centimeters, or if there's growth, or if they have worrisome features. And I'll talk about what worrisome features are in just a minute. The US is very good at picking up a mural nodule, which is a worrisome feature. It's also good at showing duct communication like you see here, which is suggestive of either a pseudocyst or an IPMN. And it's incidentally also good at looking at the rest of the pancreas, of course, to see if there's other changes of chronic pancreatitis, other cysts, et cetera. The other benefit of EUS is it allows us to aspirate fluid, and fluid adds to the diagnosis about 20% of the time, besides the information we have just on the images from EUS and the images of an MRI. So it's helpful. It is associated with small risk, as we know, but it's usually pretty acceptable. And even if we FNA the cyst, it's only about a 1-2% chance of usually mild pancreatitis that requires an overnight stay. So what about fluid amylase and CEA? I would say amylase is worthless, but it's close to worthless. The only really role of a fluid amylase is telling us that it's not a pseudocyst. So if you have a normal fluid amylase from a pancreatic cyst, it's not a pseudocyst. Otherwise, amylase can be 2,000 in any kind of cystic lesion. It's not very helpful. What about CEA? This is helpful when CEA is very low, less than 5, or if it's very high, like over 500. The problem is about 50% of the time the CEA is in that indeterminate 5 to 200, 5 to 300 range, for which it basically is, I won't say worthless, but not very effective at helping us. When a CEA is over 500, it's highly specific for a mucinous or a precancerous cyst, and that's basically why we use it. Now, just for time, I'm going to scroll through these. The main study by Brugge et al. Showed that the 192 level of a cyst fluid CEA level is the most accurate breakdown. So higher than that is 75% specific or 85% specific for a mucinous cyst, and less than that is 75% sensitive for a mucinous cyst. So that's the level we use, although as you can see, many levels have been tried in the literature, and I use the level of 500, which is much more specific. However, we miss about 50% of cases that way, so we need other tests in addition to the CEA to usually make a very specific, accurate diagnosis. So what other tests do we have? We have a fluid glucose now, which is actually very good. Well, relatively good. It's adds sensitivity to the CEA. So I'll just show you the numbers here, about 90% sensitive, about 85% specific for a mucinous or precancerous cyst. And this is based on 8 studies in the last 10 years or so. If you add a glucose to a CEA level, it's even better. It makes the specificity about 90%. So with just doing an EUS, FNA, fluid glucose and fluid CEA, 95% of the time we can make a diagnosis. It's only rare we have to do the genetic studies, the cyst wall biopsy, et cetera. And that's good. That's better than it was 10 years ago. We've gotten better. And the main thing about a fluid glucose is you can do it in the lab. It's cheap, it's quick, it's easy, it's available. You don't need to wait 3 days, and you only need a drop of fluid. What about the string sign? This is a test I do routinely. It's also very cheap, safe, quick, easy. You can do right there in the lab. What does that mean? You get a drop of fluid, you put it between your gloves, and then you move your gloves apart, and you want to see a centimeter long string of fluid. Technically, it's supposed to be longer than a second, but as long as you can see the string and it's over centimeters, it's a positive string sign. And this is only based on one study, but it basically is related to fluid viscosity. And if it's present, and you can see this string was clearly positive, it was actually more like 2 centimeters once I stretched my fingers out, and that's highly suggestive of a mucinous or precancerous cyst. When you combine the string sign, in this one study anyway, if you combine the string sign with the CEA, it's even more specific. And this is my experience in the lab too. A string sign, if it's present, you basically know it's a mucinous cyst. These patients can't be dismissed. They have to either be followed or sent to a surgeon. That's another more dramatic example. Well, super glue coming out of the tip of the needle. Oh, I need to wind down. I'm not going to talk much about US guided biopsy. That's a new study that adds to the armamentarium. It's something we can offer patients. We're actually studying it at UCH as we speak. It's about as good as CEA, but when you combine it with FNA, which is what we're studying now, it's probably going to be even better with a sensitivity and specificity of both over 90%. This is just an example of a patient that we did in the US guided biopsy on, and it made a diagnosis of serous cystadenoma, which is a high surprise because she had chronic pancreatitis and we thought it was a pseudocyst. I'm not going to talk about the guidelines. They're in my slides. They're confusing. They're discordant. They're based on relatively weak retrospective surgical data. And when applied to clinical practice, then they're actually relatively inaccurate. But we follow them because they're there and they help structure our treatment flow, but they are prone to, unfortunately, many errors. Last slide I'll really show you that you need to know is just the high-risk features: jaundice, a duct bigger than 10 millimeters, a diagnosis of a MCN, solid pseudopapillary tumor, neuroendocrine tumor. These patients need to go to the operating room. Malignant cells or high-grade dysplasia on an aspirate, they need to go to the operating room, and a mural nodule more than 5 millimeters clearly need to go to the operating room. All the others are simply worrisome features that make us careful enough to want to keep the patient in surveillance. God, I did this talk at home. It was only like 18 minutes. Isn't that funny how that goes? Shoot, I can't even talk about cyst ablation. I'll take questions in the discussion if you guys want about cyst ablation, which is the new kid on the block. We don't offer it here yet, but it's relatively safe, much safer than pancreatic surgery, which I was going to talk about the risks, but we can talk about that afterwards, should you care to discuss. Thank you, and I'm sorry to go over a few minutes.
All right, thanks, Dr. Atwell. Don't worry, we'll make up some time on the next session. Unfortunately, one of the speakers in the next session is ill and won't be here, so we'll catch up. We're not canceling lunch or anything like that. Colette Crane is an instructor of medicine in our section of gastroenterology and one of our APPs, and she's going to talk with us about updates in management of choledocholithiasis. Thanks.
Hi, my name is Colette Crane. Like Avash said, I'm a PA in inpatient GI. GI therapeutics. So I want to go over the bread and butter of what our team does, which is choledocholithiasis. Talk a little bit about what it is, how stones are formed, clinical features you may see with patients you see in clinic, how you work it up, and then time management and treatment of when to get an ERCP. So what is choledocholithiasis? I'll go over a little bit of the anatomy. Choledocholithiasis is stones in the common bile duct, and I'll use that term interchangeably. Common bile duct stones, choledocholithiasis, it's particularly in the location of the cystic duct down to the ampulla of Vater. So we won't be talking about stones in the intrahepatics. That has different etiologies. The common bile duct is approximately 8 to 11 centimeters long, and its diameter on average is anywhere from 6 to 10 millimeters. The ampulla of Vater is where it opens into the small intestine, and it's surrounded by a muscle called the sphincter of Oddi. The sphincter of Oddi is the muscle we cut during a sphincterotomy during a routine ERCP. There are many factors that contribute to stone formation. I think we're probably all most familiar with bile stasis, so the slowing down of bile through the biliary tree, making stones. This is commonly caused by strictures, malignancy, or high cholesterol, essentially making the bile supersaturated in cholesterol, making a stone. Chemical imbalances are common, such as estrogen, increased bilirubin excretion. This is seen in hemolysis. Sludge, this is most commonly seen in gallbladder dysfunction, infections, which can affect the integrity of the bile duct, and pregnancy. Remember, bile is made in the liver. It is a lipid-rich solution, and it is also sterile. And that is important when we start talking about cholangitis. It's important and plays a crucial role in digestion and absorption of fats, and it makes it easier for us to absorb fats in the small intestine. I'll just briefly go over a couple types of stones. I won't go into depth about this, but we can have primary stones. This refers to choledocholithiasis that is made directly within the biliary tree. This is less common, primarily seen in Asian populations. I think we're all most familiar with secondary choledocholithiasis. Cholesterol stones makes up almost 75% of these secondary stones. You can also have inadequate bile salt levels or function, diminished contractility of the biliary epithelium, and this can be due to genetics, hormones, and then diet. So why is this all important? So the approach of suspected choledocholithiasis really requires careful consideration because it poses a risk for your patient, either recurrent symptoms, right upper quadrant pain, or pancreatitis, or cholangitis. Cholangitis is a GI emergency. It has a mortality rate as high as 50%, and with prompt treatment in an ERCP, you can reduce mortality rate by 5 to 10%, down to 5 to 10%. So what are you looking for in biliary obstruction? Common symptoms, right upper quadrant pain or biliary colic, jaundice as the bilirubin is being reabsorbed to the skin, loss of appetite, dark urine as the kidney is working to get rid of the excess bilirubin, pale stool as the bilirubin isn't making it to the small bowel. Plus or minus fever kind of sets us up for cholangitis. And then as some of us see in clinic, asymptomatic or just very vague symptoms. The most common clinical manifestations are going to be symptomatic cholelithiasis and acute biliary pancreatitis. Patients who have symptomatic cholelithiasis or symptomatic gallstones, right upper quadrant pain after eating, their choledocholithiasis will occur in about 8 to 16% of these patients. Patients who present or manifest as pancreatitis, choledocholithiasis accounts for 35% or more of these cases. Two of the most common causes of pancreatitis being alcohol and gallstones. So what do you do? As you're seeing your patient, you start to work them up. There are two things you're going to start out with: liver enzyme tests and an ultrasound. Keep in mind what you're looking for in each of the tests. So liver enzyme tests or an hepatic panel, if you find a completely normal liver enzyme test, know that the negative predictive value is over 97%. So you can hang your hat on a low suspicion of choledocholithiasis with normal LFTs. Then follow up with an ultrasound. Keep in mind that when you're getting an ultrasound, the sensitivity is the highest for detecting biliary dilation, not for stones, although it can show choledocholithiasis. It has a relatively poor sensitivity. Biliary dilation has a very high negative predictive value as well. So you're going to get your liver enzyme tests. You may see some elevation in your ALT and AST, but primarily you're looking at your alkaline phosphatase and your bilirubin. A lot of us probably won't follow up with a GGT lab order, but you can. Remember, alkaline phosphatase is found in numerous tissues throughout the body, but over 80% of alkaline phosphatase is found in liver and bone. When there is a biliary obstruction, we typically see an alkaline phosphatase 3 to 4 times the upper limit of normal, and it's found in 75% of patients with cholestasis. So it can be very specific. Keep in mind also certain tumors can generate their own alkaline phosphatase. So if you're dealing with a patient with malignancy, we need to find the primary source of alkaline phosphatase, and that's when you'll get a GGT. GGT is primarily and very highly sensitive for the biliary tract diseases and has a low specificity for liver disorders. So if you have a high alkaline phosphatase and a high GGT, you know you're dealing with a hepatobiliary disorder. Then you'll grab a bilirubin, make sure to fractionate it. Remember, bilirubin is the as a result of the breakdown of our red blood cells. First, it's unconjugated, which we also call indirect in the labs that you get. Indirect bilirubin makes its way through the blood into the hepatocytes. It doesn't become conjugated until it's made it into the biliary system. So obstruction is most common with elevations in direct bilirubin. And one study found that bilirubin over 1.7 has a 60% specificity for choledocholithiasis. So have that as a cutoff. Then you'll get your ultrasound. Remember, the sensitivity is highest with biliary dilation. A normal caliber duct ranges from about 4 to 8 millimeters. Two things that affect biliary dilation is age, over 55, and a patient who's been on chronic opioid use. So take that into account. If a patient has had a cholecystectomy, the average duct diameter is from 4 to 10. There are other imaging modalities you can obtain. The ED likely will have a CT for you to look over. Although a CT will be better at finding choledocholithiasis, it's still the sensitivity is not over 75%. It is better than an ultrasound, but not that great. Can be expensive, and it will expose your patient to radiation. The gold standard really is an MRCP. The sensitivity and the specificity is over 90% for choledocholithiasis. And it's not so great with tiny, tiny stones. Once I go over ASGE guidelines for working up choledocholithiasis, you have the option to do a lap cholecystectomy with an intraoperative cholangiogram when you refer to a surgeon. And keep in mind the sensitivity and specificity can be upwards of 100% just based on how well that cholangiogram is. Here's a picture of an MRI and a CT. This is an MR over here on your left. The bile duct is white. You can see the distal CBD stone is black, and then there's biliary dilation upwards. On your right is a CT. That patient has a gallbladder. The CBD is dark in color. Then you can see distally there is stones. So ASGE guidelines have proposed a strategy for assigning the probability or risks of your patient having choledocholithiasis based on your initial evaluation. The probability is based on a low, intermediate, or high risk. Keep in mind a low probability is less than 10% risk of choledocholithiasis. Intermediate is anywhere from 10 to 50. And then a high risk probability is over 50% choledocholithiasis and should proceed straight to an ERCP. Just another way to view these guidelines by predicting your risk of your patient having choledocholithiasis, essentially with the same end result. Intermediate risk patients, keep in mind, have 3 options. So you can do an endoscopic ultrasound, plus or minus ERCP. You can follow up with an MRI, or you can send the patient straight to a lap cholecystectomy with IOC. An endoscopic ultrasound, if your patient's sitting in that intermediate risk, this is a 2-dimensional ultrasound. It's really well suited for biliary imaging. As you can see, the sensitivity is very high for stones, and it will be able to detect small stones, and the complications are low. Once a stone is detected in an ultrasound, we can proceed to an ERCP, sensitivity and specificity being very good, with more complication rates. The highest rate being post-ERCP pancreatitis, risk being upwards of 6.7%. Infection, our procedures are not sterile, so we can reintroduce an infection, cholangitis. Hemorrhage, most likely from the sphincterotomy site, and perforation, we poke a hole somewhere along the bowel that we didn't mean to. Low risk. Here's a picture of an ERCP. The hockey stick is our scope. We've gained access to the biliary tree. We've performed a sphincterotomy and gotten a wire up into the biliary tree and injected contrast dye. You can see 3 or 4 distal defects in white for choledocholithiasis. The pancreatic duct also opacified, and the cystic duct stumped over on your left also opacified as well. Most patients that undergo an ERCP are uncomplicated. That just means that they have less than 3 stones and the stones are small. Should you remove a gallbladder once you've identified choledocholithiasis and they've undergone an ERCP? Current guidelines do recommend that, and sending them for gallbladder removal within 7 to 14 days of evidence of choledocholithiasis. And really, this is just to prevent recurrence of choledocholithiasis, which occurs in upwards of 20% of patients. If patients are not a candidate for gallbladder removal, the other option is for an ERCP with sphincterotomy. That can be considered definitive therapy for some patients if they will not be able to undergo a cholecystectomy. I won't go into this in our talk, but GI therapeutics can also endoscopically drain a gallbladder, either by EUS or ERCP. I got this referral recently from a primary care office, elderly female, 92 years old, fairly healthy, hypertension, hyperlipidemia, but she presented with fatigue. This had been going on for months. The PCP ended up getting labs and an ultrasound. The lab showed elevated LFTs. The ultrasound actually did show choledocholithiasis. She kind of had everything across the board with biliary dilation and stones in her gallbladder. So obviously, based on our probability stratification, we would proceed to an ERCP. The question is always how quickly, when should you send them to the ED? Kind of how do you manage an outpatient in that setting? So it's all dependent upon cholangitis and how the patient is presenting in terms of their symptoms. As a reminder, cholangitis is a GI emergency. It's most commonly caused by choledocholithiasis. On average, in the United States, there are less than 200,000 cases of acute cholangitis annually, so it's not that common. A patient will present Charcot's triad or Reynolds pentad, keeping in mind that they'll have the jaundice and abdominal pain, which is your biliary obstruction, but really what points to cholangitis is a fever. In fact, patients with cholangitis, over 90% of them will present or have a fever. Reynolds pentad, you're starting to have altered mental status and a sepsis picture, which includes the leukocytosis, tachycardia, and hypotension. Reminder, acute cholangitis is a high mortality rate. So if your patient has biliary obstruction with a fever, current guidelines recommend an ERCP within 48 hours. An ERCP is preferred over percutaneous drainage. So going back to our patient, clearly she's not cholangitic. This was a stone found under ultrasound. She's stable, although tired. So refer her to GI Therapeutics for an ERCP within 2 to 4 weeks. This is an outpatient referral. It doesn't need to come through the ED, so that she can undergo an ERCP for stone removal. From an outpatient setting, we typically recommend antibiotics to be called into the pharmacy just in case the patient spikes a fever at home. We usually recommend ciprofloxacin, although keep in mind the fluoroquinolone adverse effects, or Augmentin. Tell the patient if they start having a fever, start antibiotics and get to the nearest emergency room. Otherwise, they can follow up outpatient. So lastly, I just kind of want to follow up on completely incidental findings of common bile duct stones. Often you're working up something else and stones are found in the common bile duct, patients not having right upper quadrant pain. So up till now, we've been talking about symptomatic patients. This would be a completely asymptomatic patient, no elevation in LFTs and no biliary dilation. Do you even address choledocholithiasis? The World Journal of Gastroenterology still puts a strong recommendation on offering treatment with an ERCP for all patients with stones, whether asymptomatic or not symptomatic. Although the lifetime risk of untreated CBD stones is still unknown, we know that the complications of CBD stones can be life-threatening. Hepatic abscesses, cholangitis, biliary pancreatitis, secondary biliary cirrhosis, all of which can be life-threatening. So still strong recommendation for removal of stones. Interestingly enough, an asymptomatic patient undergoing an ERCP has a much higher risk of post-ERCP pancreatitis. The risks are upwards of 20% versus when we were talking about symptomatic patients, it was around 6%. So just something to keep in mind with the patients you're dealing with. Again, across the board guidelines, 2019 guidelines, strong recommendation to remove all stones that are shown. If patients are not healthy enough to undergo basically general anesthesia for an ERCP, there is recommendations for a conservative approach, meaning watch and wait. Key points to go over. If you're working up choledocholithiasis, get LFTs and get an ultrasound. Remember, LFTs, you're looking at the alkaline phosphatase and the total bilirubin, and you need to fractionate it. Get an ultrasound, you're looking for biliary dilation. Treat all stones, whether incidentally found symptomatic or not. And it should be from an outpatient setting, 2 to 4 weeks is fine. The only time that becomes an emergency is in the setting of cholangitis. It really should be treated within 48 hours by ERCP. And if choledocholithiasis is found and they've undergone an ERCP, a lap cholecystectomy is recommended within 2 weeks following our ERCP. That's it. Thank you.
All right, thanks very much. So before we go on to our next session, we'll take just a few minutes to see if anyone has any questions. And then after maybe a couple of questions, we'll kind of pause, go into the next session, and certainly we'll all be around during the lunch hour if you have further questions. So any questions for me or Dr. Atwell or Colette? And thanks again. The other thing we can do, if people have are feeling shy, is you can, through the same Poll Everywhere app that we were using earlier, you can actually type in a question anonymously. We'll see if anything pops up. If not, we'll move on, and that's fine. Touch click.
Got a question for you, Avash.
Sure, Ben.
So in the overlap of PSC and IBD, specifically colitis and pouchitis, we tinker with this concept of oral vancomycin, and there's been anecdotal case series suggesting a clinical benefit for especially the IBD, but there's also been some evaluation with the PSC component. So I'm wondering if you could speak to your interpretation or recommendations regarding that.
Yeah, so right now the AASLD guidelines don't specifically recommend vancomycin, as you know, for treating PSC, although they mentioned that you can consider it. And Dr. Foreman, who I mentioned earlier, who was part of that group who put together the guidelines, has kind of shared with us that this was a contentious point of discussion amongst the experts as they came up with these guidelines. There are also a lot of patient advocacy groups really interested in trying to use vancomycin. It's obviously a readily available medication, but ultimately, just based on outcomes data, it hasn't been recommended. I think that if someone is already on it, we certainly don't stop it. I think in our practice, we generally don't start it just because it's not part of the guidelines, but perhaps it will be in the future, especially with the positive outcomes you mentioned with IBD. Gus.
In the absence of another question, I was going to ask you a question
Sure.
about Actigol and PSC patients, because patients coming in with getting an ERSP, for example, and refractory pruritus, nothing else we can do. In the absence of evidence, I see a lot of patients on ursodiol from other centers from here, both. And I was wondering if you had personal experience or any data outside of what I've seen that really supports that.
Yeah, so the way that I would think about it is for ursodiol, well, we talked about the PBC dosing, right? So 13 to 15 milligrams per kilogram per day. There's really kind of three categories of dosing for urso, sort of low dose, which is what I would consider 13 to 15, moderate dose, more along 20 to 20 mgs per kg, and then high dose, like we're getting to high 20s, 30. And we know that high dose urso and PSC has adverse outcomes, so we definitely don't recommend that. And I certainly would reduce the dose or stop it if I ever saw a patient referred on that. The data does not support low dose PSC, low dose ursodiol for PSC. There is some data, however, for moderate dose. So at that 20 milligram dose per kg, 20 again mgs per kg per day. And with that, there's some evidence of reduction in the alkaline phosphatase. And so it is actually appropriate to consider ursodiol in those patients who have an elevated alk phos, because alk phos is a surrogate marker for outcomes in PSC. There's increased mortality the higher the alk phos is. So if you can try and get that number down, given the data, PSC with a high alk phos, you can consider a moderate dose, about 20 mg per kg. And so we do at least pursue that in some patients. If someone is referred on ursodiol, certainly I don't tend to stop it. They can have a rebound pruritus that can occur in many of those patients as well. So those are some factors to consider. It's a really good question.
I have a question for Dr. Atwell. Well, two. The first, I guess, in patients with an incidentally discovered small IPMN, what guidelines do you tend to use? And are these patients where you talk about discontinuing imaging at some point?
Yeah. So Tom is going to be our advanced fellow and shortly, and he asked a really good question. I guess everybody could hear it. I follow the ACG guidelines. I think they're the most kind of close to home. They're also the most, I think, balanced. They're not tend to be more surgical or internist biased, I think. So I follow their guidelines in terms of imaging and worrisome criteria. And your second question was about the discount. Oh yeah, because that was a different set of guidelines. That's why I blocked it out. So there's controversy now about if and when to discontinue surveillance in patients that have in the pancreatic cyst population, patients that have no worrisome features, cysts smaller than 3 centimeters and stable in size after 5 years, to discontinue MRI or CT or whatever surveillance imaging tool you're using. There's only one society that backs that up, and that's the AGA guidelines, the American guidelines from 5 years ago. And there's this is about a 30-minute topic. Taylor even gave it a grand rounds on the discussion at DDW and I personally will talk to the patient about it. And there's like taking care of the individual patient, doing everything possible. But for her, on one side, and the other argument is for taking care of the U.S. population, the economy, and saving costs, et cetera. And I'm kind of in the middle, and will offer it to the patient who's particularly anxious and has a family history, for example, but not routinely. If it's small and no risk, high risk features, and they're over 70 and they're not really interested in the Whipple, it's in the head, I will
try to push them not to get any more imaging. So it depends on the patient, but it's a complex issue that's very controversial. It's a great question. Yes.
Candidate and not an ERCP candidate, what is your next step?
So if I understood the question correctly, somebody with ascending cholangitis who's has a stone, presumably, and is sick and can't get an ERCP for what reason? Well, because of cholangitis and sepsis or because of comorbidities, et cetera? Okay, well, that's a different issue because if it's cholangitis, I would say the patient's too sick not to get a ERCP or a PTC or some kind of intervention to decompress the biliary tree if they're dying of sepsis. Now, if they're, so you bring up a really good question. I mean, we've got a couple of options. I think the safest, simplest option, they can be done if they have a gallbladder and it communicates with the bile duct. They can get a gallbladder drain by IR without sedation with local anesthesia only and decompress the biliary tree that way. I understood there's not great data for it, but they have a patent cystic duct that should work. That's what, if patients don't have a gallbladder, then it's tricky. Then I think you're going to say, okay, we have a patient who's got severe cholangitis. He or she's going to die without it. And the only way that PTC is probably riskier than ERCP. They're both going to require sedation, presumably. If the biliary trees die, we've had a couple of cases of Denver Health where I'm not there and they have to go to the university and be transferred and they're too sick to transfer because of multiple pressors, et cetera. And IR will occasionally do a PTBD, percutaneous drain, in a patient with local sedation only, without sedation, even with a non-dilated duct. But it's really unusual and you have to discuss, I mean, if they're really too sick for surgery, then you could even bring up palliative care, not doing anything, of course. But if they have a reversible cause and it's just a matter of decompressing the duct, that's usually what we would do, or just bite the bullet and do an ERCP, understanding they're probably going to die without it. I mean, too sick for an ERCP because of comorbidities, well, I'd say that they have cholangitis, they need something other, going to die from that. Potentially. That answer your question?
All right, just quickly answer the question that came up here. We'll move on to the next session. The question is, in a PBC patient on Ursodiol who is not having a therapeutic benefit, so still with an elevated alk phos, how long would you give it on monotherapy before adding switching to Ocaliva? So like I said, typically we see the response to Ursodiol within the first 6 to 9 months. So that'd be the time frame that I would be thinking about, in the 6 to 12 month time period before escalating therapy. So great question. And thank you again to Dr. Atwell and Colette for excellent talks. We're going to move on to the next session. And so we're really excited to do these multidisciplinary clinical vignette sessions for the rest of the day up until the rooftop reception. Just another plug for that later. And after that, we'll have a really exciting debate involving 2 of our fellows. But we added these multidisciplinary sessions to this year's agenda just because of how multidisciplinary the management of these conditions within GI and hepatology tends to be. So the first presentation, or excuse me, the first session is going to be a multidisciplinary approach to alcohol-associated liver disease. And before I introduce our speakers for this, I want to just start with a clinical vignette very briefly. And this is a case that certainly we often see in our practice. So this would be, for example, a call from a hospitalist at Southwest Memorial Hospital in Cortez, Colorado. That doesn't actually exist. But anyway, inquiring about possible transfer of an inpatient for liver transplant. So for example, a 31-year-old man with severe acute alcohol-associated hepatitis presented 2 weeks ago with jaundice, stopped drinking about a week before admission because he was not feeling well. And some initial data showed an initial discriminant function of 72, a MELD score of 30, bilirubin of 31 on arrival with an INR of 2.1. The patient was treated with prednisolone, and based on a day 4 Lille score was felt to not be responding. Subsequently developed progressive ascites, spontaneous bacterial peritonitis, and then hepatorenal syndrome, so a dramatic sudden increase in the creatinine. So we're asked, is he a liver transplant candidate? Well, assuming the patient is ultimately decides to transfer here based on a discussion between providers, it's transferred here to the hepatology 4 with worsening renal failure, decreasing urine output, a MELD score now of 45, found to be volume overloaded with ascites, and has a test result, which we'll talk about more, elevated at 486. The patient comes with his mother, who notes that on several occasions, she's asked him to cut back given concerns for excessive alcohol use, though he had not previously stopped until he became sick. So that's the case, just to kind of have in your mind as we go through this session. We'll start off with Dr. Jay Burton, who is a professor of medicine in our section of hepatology. He is the section head, as well as the medical director of liver transplantation, also a mentor of mine and the one who recruited me back to the university, which I'm appreciative of. So Jay is going to start off. Dr. Emily Harding Theobald, who's up on the stage here and was our transplant fellow last year, will then take over after that. Jay, thanks. Thank you.
Well, thanks for the opportunity to participate in this meeting. So I'm going to talk about alcohol-associated liver disease, a crisis in America, and the critical role of liver transplantation. I don't have anything relevant, though I do drink beer and I do like bourbon. So the total number of transplants in America by diagnosis, you can see that alcohol has been going up, and it's been going up well before the pandemic occurred. This is a recent slide that kind of shows the distribution of chronic liver disease in America. And as you can see here on the right, you've got the percentage of alcohol is about 48%. About half of the cases of people undergoing liver transplant for non-liver cancer diagnosis is alcohol. And then the second indication is metabolic associated or dysfunction associated liver disease. So alcohol certainly has become a huge problem, and half the, I would say 80% of the patients we see in our transplant clinic for evaluation are alcohol these days. So as you're all probably aware, you know, the pandemic hit and everyone decided to drink alcohol. Everyone was staying home in their pajamas, learning how to use Zoom and having cocktails at about 2:30 in the afternoon. But this was a huge problem. We saw this immediately in our hepatology clinics. And why was this? Well, you know, you had social isolation. You had a lot of people with underlying psychiatric illnesses were told they couldn't leave their home, and if they did, they were going to die. And people were losing their jobs, and there was increased psychosocial stress, and people turned to alcohol. And this really resulted in an increased rate of hospitalizations related to alcohol-associated liver disease, increased mortality from this, and rates of liver transplant for alcohol went up as well. You know, alcohol-related deaths between 2019 and 2020, you know, the time of when the pandemic occurred, went up 25% in 1 year. And in the preceding preceding decade, there was only a 2% increase every year. So this was quite an increase. Of course, you know, there were a lot of people dying at that time, and, you know, all mortality increased by 17% due to the effect of COVID. The change in alcohol-related deaths from 2019 to 2020 is between the time period of the pandemic saw increases across all age groups related to alcohol, though particularly young people. Now, as you know, alcohol-associated liver disease is a spectrum of diseases. You know, you have a normal liver, you expose it to a lot of alcohol, it usually becomes very fatty in most cases. It's probably unusual to have a, you know, significant liver disease that goes from normal to without going through steatosis. But one can develop alcohol-associated hepatitis with or without cirrhosis. Alcohol-associated hepatitis is an acute onset of symptomatic hepatitis from alcohol. It presents in 10 to 35% of patients who are hospitalized with severe alcohol use disorders. Half of people you'll see with severe alcohol-associated hepatitis will have underlying cirrhosis. And it has a very high mortality of 30 to 40% at 1 month in severe cases. And really, a pharmacologic treatment with steroids is really the only thing to offer people, and it only has a benefit in half of patients. If you look at some of the changes in relative rate of alcohol-associated hepatitis during the pandemic, the baseline prevalence was about 2% for people undergoing transplant for alcohol-associated hepatitis. This increased in a matter of several months after the pandemic, about 200 to 400%. Both in listings for alcohol-associated hepatitis as well as people undergoing liver transplantation. The impact of the pandemic on the wait list, we saw, across the nation, there were about 10 people a month being added to the wait list with alcohol-associated hepatitis. This went up to 20 to 30% in a matter of months. And liver transplantation, there were about 10 cases per month in the United States with alcohol-associated hepatitis. This doubled up to 20. Now, when you see patients and you're talking to them about what they drink, you need to not only know what they're drinking and how much they're drinking, but you should understand what a drink is. And you shouldn't just take what a patient tells you is a drink. As you're, this afternoon, that we may be offered some cocktails, perhaps. Okay, all right. 5% alcohol, 1 can of beer, but there's a lot of beers out there, especially in Colorado with craft beers that can be up to 10%. So if you're drinking one of those, that's 2 drinks. There's 5 glasses of wine in a bottle. So a lot of people think, I have some patients who have glasses that can hold an entire bottle of wine. So it's important to kind of understand this and to really press your patient to really understand this. And I think most patients don't have any idea how much they're drinking, and they drink at least 2 to 3 times more than they think they do. Just so you know, the Solo Cup outlines how much is in there. There's an ounce of liquor on the bottom line. There's 5 ounces of wine on the next line, and then 12 ounces of beer on the next line. Relative risk of developing liver disease related to sex was really determined based on this study from the mid-1990s that showed that if women had a risk of developing alcohol-associated liver disease when they had as little as 1 drink per day, and men it was between 2 and 3 drinks. So moderate drinking for a woman would be 1 drink a day. And I think most women who split a bottle of wine with their husband at home are probably drinking half the bottle with their husband. So that's 2.5 drinks. So women are more susceptible to alcohol-associated liver disease from drinking. And 2 drinks a day would be moderate drinking for a man. Binge drinking would be 5 or more drinks for a man, 4 or more for a woman at a single occasion. And heavy alcohol use would be binge drinking on 5 or more days in the past month. Alcohol use disorders, most patients who have alcohol-associated liver disease are going to have an alcohol use disorder. I think you can these are kind of just guidelines of what would define mild, moderate, and severe alcohol use disorders. I keep these in mind and just kind of go over patients, what they might be doing and point out that they probably do have a disorder of alcohol use. Especially in terms of the amount of alcohol they're drinking, because I think a lot of people don't realize they are drinking a lot of alcohol. The desire to cut down and have the inability to do that, cravings, failure to fulfill life commitments, impacting their social and occupational activities. And of course, withdrawal and tolerance are quite significant problems. Alcohol use disorder, mortality in the United States related to alcohol use disorders. This is just a little heat map that between 1980 and 2014, and anything that is light pink to purple is significant increase in death from alcohol. Why the Southeast? Maybe they switched to eating donuts, and maybe that's where our problems with NASH occurs, but. Throughout the United States, you can see there's been a huge problem over the past decades with a significant increase in mortality related to alcohol. So, an interim summary here is before the pandemic, use of alcohol use disorder rates in all demographics, especially young women, were increasing in America. And, the pandemic just lit that on fire. The burden of alcohol-associated liver disease exploded with the pandemic. And alcohol-associated liver disease is now the leading indication for liver transplant in America. So defining alcohol-associated hepatitis, this is characterized by heavy alcohol use. Typically, for someone drinking alcohol 2 to 3 months. I did see a patient recently in the hospital who had a liver transplant in the last year, and the house staff were amazed that he was able to have alcohol-associated hepatitis in his new liver. I think it just points that if you put your mind to something and you really, really try hard, you can do this. Anyone can do this. But heavy use for 3 months can cause alcohol-associated hepatitis. And one thing that's also important to realize is you can quit drinking alcohol up to a couple months and still develop alcohol-associated hepatitis. And I see a lot of patients coming into my clinic who are really sick and they say, well, but I quit drinking 2 months ago. How could I have alcohol-associated hepatitis? It's characterized by on biopsy. If you happen to do that, I mean, I sometimes think that's like biopsying a duck and wondering in something that has feathers and it's flying and duck feather quacking and webbed feet, but it will show steatohepatitis and severe fibrosis in most cases. A lot of patients are going to have tender hepatomegaly. They're going to be decompensated with ascites. And laboratory values, these patients are going to be jaundiced, most likely deeply jaundiced, with minimal elevation in their serum transaminases, with a predominance of AST elevation. And if the AST is more than 400, that's probably something else in addition to alcohol-associated hepatitis. There's a lot of ways to determine severity of alcohol-associated hepatitis. The one that's probably used most often is the Madry discriminant function, which you can all get online and put a little calculator in. Assuming your lab reports what a prothrombin time is, I think most people live their life using INRs. MELD score can be used. There's the Glasgow alcoholic hepatitis score. And then, response to therapy is largely used looking at the Lille score, which really looks at the improvement in bilirubin mostly after between 4 and 7 days. Corticosteroids for alcohol-associated hepatitis. This has been looked at, since the 70s into the 90s. 13, randomized controlled trials that have looked at this. I think people question this, but I don't question it. I think there is data that steroids do help patients who have alcohol-associated hepatitis. I think there's a lot of fear of using steroids and a lot of belief it doesn't work, but I'm a big believer in a trial of steroids. I mean, if you think you can't give steroids to someone for 4 days, then I think there's probably another problem there. The Lille score, I think, is a wonderful model to look at the response to steroids because, I mean, there's not many things in medicine that can draw a correlation between someone who's going to do well and someone's going to do badly to this degree. And this can be done even as 4 to 7 days. So I mean, this maybe even can be done in the hospital before a patient leaves the hospital, or it can be done soon after a hospital discharge. So overall management of alcohol-associated hepatitis is identifying it, determining severity. In most patients, I would give a round of corticosteroids. Traditionally, a lot of studies use prednisolone because it'd be better absorbed and doesn't require metabolism in the liver. But I think sometimes that can be hard to find. I think prednisone is fine. And then determining their Lille score. If you have a favorable Lille score, then you should continue the steroids for a month and then do a slow taper. And if you don't respond, then that's where you're really considering liver transplantation for the treatment of alcohol-associated hepatitis. Now, in terms of fixed periods of sobriety for liver transplantation, there are no national or any international mandates on sobriety for a liver transplant. And I will tell you that here at the University of Colorado, we have never had a mandate in the 20 years that I've been here. However, I will tell you that everyone thinks we do have a mandate of 6 months sobriety. So I will tell you right now, there is no mandate as someone has 6 months sobriety, and there's nothing worse than seeing someone at 6 months, 1 day who has a MELD score of 40 who has done nothing. There's nothing special about that person either. They probably would have been better off being seen 5 months ago to really start working on things. I mean, a 6-month rule is really a medical justification because if you can be sober and quit drinking, a lot of times you'll get better and you might not need a liver transplant. So that's certainly, there's always a balance between who's going to get better and who isn't. And as I say, a lot of people are going to have high risk for death within that 6-month period. And as a prognostic tool, having, sobriety, fixed period of sobriety, in medical crisis and frequent hospitalization, it's really unknown whether that's of any help anyway. Sobriety is really only robust in terms of being sober from alcohol if you're sober for 5 years. And I can argue if you're sober for 5 years, you probably don't need a liver transplant. And mandatory sobriety has the potential to encourage dishonesty with the patient. They're going to end up lying to you because they think if they tell you they're having a slip or drinking that, they're not going to be a candidate. There's a lot, if you look at, these are things that I look at when I think about someone I'm seeing in terms of whether they would, the risk for relapse. If someone comes in and says, look, I have an alcohol use disorder, I need help, they have insight and how it's impacted them. They come with social support, they have, substantive activities, they have some hope about the future with sobriety and they can see the negative consequences of their alcohol. That patient's going to have a potential to do well. Someone who comes in with an underlying psychiatric disorder, a personality disorder, a strong family history where everyone in their family has alcohol use disorder, someone who's drinking more than 10 drinks a day, someone who's failed rehab multiple times, someone who's had multiple DUIs, has done court-mandated rehab, someone who has other drug abuse history, maybe except marijuana. But those patients are not going to do well. So, I mean, the real question is trying to find out where those are. Sometimes they're quite obvious, and then there's sometimes some gray areas in between. Now, survival benefit of liver transplant with severe alcohol-associated hepatitis. This was a study in the New England Journal in 2011 and showed that if you have severe alcohol-associated hepatitis defined by a Maddrey discriminant function over 36, you failed steroids. Well, guess what? If you do a liver transplant, you're going to do well. So I don't think it's necessarily surprising, but it was really a proof of concept that this could be done. However, when you look at this study, I mean, this was a study done in France, and the determination of who got transplants was a multidisciplinary discussion of, much like we do in our own practice. 2.9% of all the transplants performed in these studies was due to alcohol-associated hepatitis. That was only 8.3% of all the patients with alcohol-associated liver disease. Only 1.8% of the transplants were for alcohol-associated hepatitis. And people did relapse, and we have to expect that that's going to happen. This has been looked at in the United States, and there are, pretty decent survival for transplanting these patients, though, as you can see, there is not insignificant risk of relapse. And those people who have sustained alcohol use, people more than 100 days after transplant who continue to drink alcohol do have increased risk for death from alcohol-associated hepatitis in their transplanted liver. So we developed a limited sobriety pathway even before the pandemic, and I'm glad we did so we could take on this problem in America. When we talked about this, it was like, who is this for? This is for people with alcohol-associated hepatitis. This is not people who just have been drinking for decades and have decompensated cirrhosis. It is for someone who has a first presentation of decompensated alcohol-associated hepatitis. It's not the patient that's been coming into the hospital every few months and being discharged and goes back to drinking. It's a first presentation. It's for people who are who have medically refractory alcohol-associated hepatitis, and that's defined as a discriminant function over 32. A Lille score is not improving. And the patient needs to admit that they have an alcohol use disorder. If I see a patient who I think has an alcohol-associated hepatitis and they tell me they don't drink alcohol, okay, well, that's not a candidate. So or we're dealing with another disease. And the patient has to be able to engage in the process. If a patient can't give me a history, if a patient can't tell me why they drink, and have some commitment to their, future of sobriety, then they're not going to be a candidate. So, severe encephalopathy would be an exclusion factor. So we developed this pathway and we've kind of modified it over the past 5 years. But it really starts with, having someone in front of us, and that could be an inpatient or an outpatient. And things I would look for is, did they have prior knowledge that they had liver disease from alcohol and kept drinking? A lot of times there might be some inkling of it. However, I see a lot of times people have big fatty livers from alcohol and their referring provider thinks it was all due to metabolic problems and didn't really involve, looking into their alcohol use. Do they have insight into how alcohol has played a problem in their role? Do they have good social support? Do they have other comorbid psychiatric disease? Have they had failed attempts at alcohol rehab? We have a kind of a policy that if you have a transplant hepatologist who feels that they can advocate for a patient they're seeing, we then have them see our transplant social worker and our transplant psychologist. They see them independently. and they make their own determination. And if the social worker and the transplant psychologist agree that they are a candidate, we then initiate a full transplant evaluation with our entire team. If a patient is deemed a candidate from a multidisciplinary discussion of their case, we then have them sign a memorandum of understanding, something that's entirely unenforceable and not a legal document, but it does outline what we expect from these people. And it's signed by the patient, it's signed by a family member, it's signed by the social worker, and it's signed by the hepatologist. And it's basically an agreement, it's put in a chart, and we refer back to it when someone's telling me that they don't really want to go do treatment or something. And then we've recently added a new part of the member to our team, a substance use navigator. And this is a social worker who has experience in drug and alcohol addiction. And her role is to engage the patient pre-transplant, peri-transplant, and post-transplant to ensure that we keep them engaged and make sure that they realize that this person is going to see them through the first year. They're going to be following their alcohol screens after transplant. We do PEth test every month for the first year after liver transplant in these patients. And they're going to help facilitate post-treatment alcohol treatment, which I would say we had this goal of just sending everyone to inpatient rehab after a liver transplant. These patients are often sick, sometimes they're still on dialysis. They're mentally and physically debilitated and require some time. So a lot of patients are going to do an intensive outpatient program. Our success with this program, I think, the first 30 patients we put through this program, we didn't have a single patient relapse, which told us we were probably being too restrictive because there should have been people relapsing. We made some kind of modifications. I can't really tell you how we modified that because it's all pretty subjective, but the next group of patients we looked at, we had about 20 or 30% of people relapsing, which is probably what one would expect. So I think in conclusion, severe alcohol-associated hepatitis has a very high mortality. It's a huge problem in America. But with very careful patient selection, favorable outcomes are possible with liver transplantation. And with that, I'll end. Thank you.
Thank you, Dr. Burton. Next up, Dr. Harding Theobald, who is on faculty at Denver Health and also works with us here at the University of Colorado on a multidisciplinary clinic that she will discuss further right now.
Okay, all right. Thanks, Dr. Burton. I have no disclosures. And for the next 10 minutes, I'm going to talk about the increasingly overlapping space between addiction and hepatology. With respect to the patient in the clinical vignette that we talked about, this largely refers to sort of the post-hospitalization outpatient follow-up. Basically, if he makes it through that hospitalization without going to transplant on the high-risk pathway, how do we then manage these patients when they get to us in clinic? They're often still extremely sick, now in a fragile early recovery period from their addiction. And so I want to address alcohol use disorder in the context of liver disease, both broadly and also in terms of the medical addiction therapy we use, or MAT. So to start off, there we go. So to start off, one thing that I want to get across in this talk is that we need to understand the current epidemic as something of a new era in alcohol-associated liver disease. A great deal of the data and the thinking around alcohol liver disease was developed in the era of hepatitis C. And back then, the alcohol use, that population was older. They were lifelong alcoholics with usually chronic cirrhosis. And by and large, in this area, the alcohol use population that we're seeing is now young patients. These are, typically in their 20s or 30s. And they're no longer considered to be too high risk for transplant, as we talked about. So in 2018, we had the Accelerate AH study that began to open the doors for transplant of these patients in the US. And at UCH, we've now transplanted, I think, over 65 of these patients with short duration sobriety. So why is our patient population changing? The patients that I've admitted to the hospital from alcohol liver disease clinic recently have been 24, 31, 28. They have life-threatening ALK-HEP and hepatorenal syndrome most of the time. And from talking to them, I think that the most important thing for all of us as clinicians to understand and conceptualize in treating these patients is that alcohol use disorder is often the symptom and not the primary illness. So this is a heat map that shows the rate of what is called deaths of despair, deaths attributed to alcohol, drugs, and suicide. And the x-axis is the years from 1990 to 2020, and the y-axis is ages 25 to 75. At the top is bachelor degree, is people who have a bachelor's degree, and the bottom is those without bachelor's degrees. And increasingly, very clearly, there's a substantial increase from 1990 to 2020 in deaths of despair, concentrated almost exclusively among those without bachelor's degrees and increasingly occurring at young ages. I think that this really drives home for me. This picture explains to me kind of the degree of distress that exists in these communities where our patients live, and also why we don't necessarily see or feel sort of the fire that's raging through the social fabric of this population. Because this is where a majority of our alcohol use patients live, even though most of us, have bachelor's degrees and mostly only know people from that population. So what does this have to do with the clinical practice of addiction medicine and hepatology? As we try to take care of patients with severe addiction, I think many people will relate to a sense of randomness, that the addiction is almost something that exists outside of the individual patient. Sometimes I think it feels like the patient is sort of stuck on the inside of a tornado, and whether or not they escape from it has more to do with the tornado that they're in than it does with the individual that's inside. And the complexity of understanding the interaction between an alcohol use patient and their environment is something that we see over and over again in the data studying these groups. So it's extremely challenging to predict, as we said, who will relapse into alcohol use. It's also challenging to predict who will survive their ALCHEP without a transplant. This is data from the UK, from the NHS, but it looks similar in the US. And when we look at patients according to their socioeconomic deprivation indices, which is the top box, the two boxes I've outlined, alcohol-specific mortality is more than two times greater among the most deprived patients compared with the least deprived patients, despite the alcohol harm paradox, which refers to the fact that these patients typically consume less alcohol overall. And there are a lot of hypothesized explanations for the alcohol harm paradox. There's healthcare access, there's clustering of lifestyle risks, there's binge use patterns. But the most important point to recognize here is that in aggregate, alcohol liver disease outcomes have a stronger relationship with things outside the patient, a patient's zip code, than they do with their actual alcohol intake pattern. And studies have even shown that geography has a powerful effect in the physical reinforcement of addiction. Many patients truly say they cannot get away from alcohol. So there's someone in their home who is still in abuse. There's alcohol use that's rampant among their extended family. So anytime they socialize, they're going to see alcohol. And often it's prevalent throughout their neighborhood. There's strong evidence, these are sort of geographic studies that show that the segregation of alcohol retailers is heavily concentrated very disproportionately in low-income and non-white communities, and reinforces alcohol use disorders through simple availability. So once you begin to conceptualize alcohol use disorder as something that is heavily rooted in sort of the structural, cultural, and social environment in which an individual lives, this becomes a really big problem for the goal that I think everybody has of maintaining equality or equity in access to transplant. So at UCH, for instance, we are the de facto transplant center for New Mexico because they don't have one. And we know from studies in New Mexico that every demographic group, which is the blue and yellow bars here, dies of their alcoholic liver disease at double the rate of their counterparts nationwide. And this cuts across race and ethnicity. You might say, oh, maybe this is related to Native American reservations. It's really not. It's in all the groups. And so how can we as a transplant center deal with a known risk for worse outcomes among alcohol use disorder patients living in New Mexico, while also sort of supporting, equity in transplant? To keep our doors open, centers have to maintain exceptional post-transplant outcomes. So we end up being forced to find a balance between, on one hand, organ stewardship, making sure that organs go to the patients in whom they have the best chance of sustaining a long life. And on the other hand, maintaining some degree of equity in who we offer transplant to. And if I told you that we didn't transplant patients from New Mexico in order to prioritize our outcomes at our center, that would seem completely unacceptable. But so would the reverse. If the program was closed because we focused on absolutely transplanting all of the patients who need it from there, giving organs to patients who are potentially twice as likely to die or relapse from their alcohol use disorder. So to summarize a little bit, the role of addiction medicine in hepatology is just so much more complicated than medication treatments for the neurobiologic aspects of the addiction. This diagram is just my way of thinking through and intended to show that when we see patients in addiction medicine clinic, they just have this many layers of reasons why a person continues to drink. There are sort of the expected things. We have mood disorders, complex PTSD and trauma, physiologic cravings, avoidance of withdrawal. And we have things for those. We have SSRIs and counseling intensive programs, naltrexone, we have medical detox programs. But we also hear from a lot of people that there's a lot of loneliness and shame, that there's boredom, loss of agency from being out of work, financial stressors, like I said, families and friends that keep drinking around them, and finding solutions to these things, ways to lift them out of the home environment that they live in or find work or create new peer support networks. That's why addiction medicine, especially in liver disease and sick patients, is just about as multidisciplinary a problem as you can get. So what do we have? In the clinic room, sitting with the patient, we are all familiar with the 3 FDA-approved medications that everyone uses as best we can: acamprosate, disulfiram, and naltrexone. We have both oral and intramuscular naltrexone. Most commonly in hepatology, we see the use of acamprosate, and that's AASLD's drug of choice because of rare reported cases of hepatotoxicity. And I think people are certainly worried about using naltrexone in our sick liver patients. I will say that in addiction medicine, the overwhelming narrative is that we should be slightly less afraid of naltrexone, not to be not cautious with it, but the doses of naltrexone associated with hepatotoxicity are 300 milligrams. Those exceed the dose used for alcohol use disorder, 50 milligrams orally, pretty substantially. And while we certainly see liver enzyme elevation sometimes, it's reversible with cessation, and it's not something that's going to sort of decompensate someone's liver or cause, medical consequences and harm. So I think in general, we should all challenge ourselves a little bit to be more comfortable using this medication up to, for instance, an AST/ALT of about 3 times the upper limit of normal. In our clinic, we use it, but we also don't use it in our sickest patients. So how about the efficacy of these drugs? As everyone is aware, naltrexone is never going to be an adequate solution to alcohol use disorder on its own. This is a graph from one of the larger RCTs of medium and high dose injectable naltrexone, and that removes issues of compliance. And although it's a little bit hard to see, this graph shows cumulative heavy drinking days. The lightest line is the placebo arm, and the darkest line is the high dose injectable naltrexone, and the other one is the middle dose injectable naltrexone. So the estimate that came out of this study was a reduction in heavy drinking days equivalent to 2 to 3 days per month. In this study, the effect was not significant in women, and it didn't increase the number of days of total abstinence or reduce what was defined as risky drinking practices. And that's IM naltrexone, and that outperforms PO naltrexone, acamprosate, and disulfiram in all of the studies. So don't misunderstand me. Patients should absolutely be offered MAT at every touch point with the healthcare system because it is the best thing that we have, and it has been shown to have efficacy. But we need to approach medical addiction therapy also with our eyes wide open about exactly what it is we're offering to patients, that this is really just a little tiny leg up. So we don't have answers. Certainly things are moving, like I said, towards a multidisciplinary approach. As Dr. Burton described, we're increasingly using a holistic approach to the assessment of patients with alcohol use in need of transplant. We're beginning to employ a lot of counseling and social work-based support structures in the peri-transplant, post-transplant period for our high-risk pathway or our early sobriety pathway patients, and finding that fairly successful. Analogous to our post-transplant intervention, we've also built a pre-transplant clinical pathway in the form of a multidisciplinary alcohol liver disease clinic, where we do our best to kind of make it our focus to address as many of these problems in that diagram I showed you as we can. So we have co-located addiction medicine and hepatology appointments. Patients who wish to engage in the program can be followed intensively for 3 to 4 months. Basically, we'll see them, if they're sick, we'll see them every 3 weeks. If they're not sick, we'll see them every 6 weeks. Providing them sort of frequent counseling, individualized approach to resources, MAT, and early referral to liver transplant if needed. And we also work closely with kind of the third and fourth legs of the stool here, which provide both escalation and de-escalation as needed. So for patients who need more support, we have the Cedar facility. We actually have 6 patients from our clinic currently in Cedar, providing inpatient rehab, IOP, and medical detox. And then for patients who de-escalate their needs, we have a PCP named Christine Neeb, who runs an addiction-focused primary care clinic at the university, and she sees many of our patients in conjunction with us and then afterwards as well. So what have we learned so far from this effort? The first thing is just that alcohol addiction is really hard for people to escape, and it's really hard to treat. Even the most committed patients can relapse at any time, and our ability to predict who will relapse is shaky at best. Another thing is that not all relapses are a threat to liver health. There was a recent study that found, similar to that French study, that among post-transplant patients who relapse but reestablish sobriety, survival is the same as those who do not relapse. It's patients who relapse and then sustain their alcohol use who then have a really significant decrease in their outcomes post-transplant. I've begun to think of patients in sort of engagement profiles. I've sort of excluded disengaged and disinterested patients here, but those certainly exist as well. Sometimes we meet people and they just really aren't interested. And so in some ways we act as a little bit of a selection tool to kind of show who is willing and who is interested in going forward and trying their best to get to transplant if they need it or to get to sobriety. There are patients who are sick and sober. That's that top yellow box. I think of them as potential transplant candidates. There are patients who are not sick. So they had ALK-HEP, but they experienced near full liver recovery. And then there are patients who are sick and will probably never get sober. And we call this our palliative or harm reduction pathway. And it's become clear that there's still very worthwhile work to be done with those patients as well. These are multiply relapsed people who society at large has largely sort of shut the door on, and listening to them, taking them seriously, investing effort that's coming from the medical system has some weight. And so we focus on cutting back, extending their time with their kids. And even if they really will eventually die from this, it's pretty meaningful for those patients in that time frame, I think. And the other thing I want to point out is, just like Dr. Burton said, for ALK-HEP patients who maintain sobriety, they get better at a surprising rate. There are patients inpatient who will not survive to discharge, but I think that this is something that we need to understand and give patients a degree of optimism when we see them in clinic, that if you do maintain sobriety, you can often get back to, yes, you'll have some fibrosis, you'll have cirrhosis on your imaging, but you'll have enough liver to sustain your body for the remainder of your life. So the clinical outcomes are honestly good, very good there. So finally, what comes next for addiction medicine in ALD? After saying that medications are not the answer, I hope that we can find a medicine that helps. It will be a long time before we have any data on this, but the patients are telling us that GLP-1 receptor agonists might be a novel change in this space. As best we understand it, GLP-1 agonists result in a decrease in nicotine, food, and alcohol-related dopamine release in the reward centers in the brain. Anecdotal experience is that patients experience a potent reduction, I would say, in the intrusive thoughts that are related to their alcohol use. I have a young gentleman who said to me, I have never been able to stop thinking about alcohol for an hour. And now I rarely think about alcohol and it feels incredible. And he has maintained sobriety since he's been on his GLP-1 after not being able to try to maintain it for a very, very long time. So coverage, of course, is the limitation here. Most patients with AUD are on Medicaid. They're not a lot of them who have the ability to qualify for coverage, but this is a someday thing, we hope. And then even further down the line, I think that the real answer is probably, as you might expect, societal cultural change. In just one generation, on the far side, you can see that we virtually eliminated the use of tobacco use among young adults through decreased social acceptance. And these graphs over here show that among different countries, these are different countries in their alcohol per capita consumption and their alcohol use disorder prevalence. And basically, where alcohol is used, alcohol is overused and people slip into addiction. And so decreasing use broadly across society is going to be an important step as much as we like alcohol. I think real change is going to come from prevention in the form of social programs to discourage alcohol use, educating people on the dangers of alcohol use, making sure that women in particular understand just how little that they can drink to stay healthy, and of course, addressing the inequalities that underlie the complex structures of addiction, which is an even bigger challenge. And that's it.
All right. Well, it's never easy to be, I guess it's not easy to be right after lunch or right before lunch in this case. We will extend the lunch a little bit so everyone has some time. I think that was a great session, very thorough presentations by Dr. Burton and Dr. Harding-Theobald. Any questions about this? This is obviously a really complex topic and something that we see a lot of in our practice. Dr. Brown, we'll bring a microphone over to you.
Thank you. Jay and also you, there's evidence that non-alcoholic fatty liver disease is increasing rapidly and the transplants for them is increasing rapidly. Can you talk about the association between that and alcoholic liver disease? In other words, does the presence of or the phenotype for non-alcoholic liver disease make alcoholic liver disease more severe?
You mean someone who has alcohol and like metabolic alcohol associated liver disease?
Yeah.
Well, we certainly see that. I mean, I must say most of my patients, I guess, if you're drinking too much and then you have other risk factors, the alcohol seems to be the primary thing. There definitely is an increase in, if you look at most of the transplants done today are, majority are for either alcohol or non-alcohol associated liver disease. I think the difference is most of the people we see for alcohol are younger people who are healthy and don't have any comorbidities, whereas most of the people who have, metabolic derangements that lead to a fatty liver disease also have, obesity, diabetes, high blood pressure, coronary artery disease. They're typically older. So there's usually that patient population usually has some relative maybe contraindications to transplant, particularly related to cardiovascular risk and obesity. Your question about do we approach them differently, or is there a alcohol? How does I guess did I answer your question?
I think you answered it. The question is, does the presence of the phenotype for metabolic alcohol, metabolic associated liver disease, does that make alcoholic liver disease more common or worse because they have this underlying liver phenotype?
I mean, I guess one could argue, they may have a problem with two addictions, too many donuts and too many Budweisers. But yeah, I can't say I've really seen I would say people pretty fall into two categories. I mean, occasionally, we do see a lot of this Met ALD, but when you go to transplant, I find that the alcohol probably is the primary driver in most of those patients, I think. Because if you quit drinking alcohol, you can get better. People with MASH, unless you lose 50 pounds, usually they don't get better by the time they decompensate. I mean, when you decompensate from MASH, you're not going to get better. If you decompensate from alcohol, you have a great potential to get better. There's no sobriety for 6 months from donuts in the latter group.
And on that note, we will go and eat, and then later go upstairs and drink. So please make sure to mingle with each other and with us. Certainly, if you have more questions, I want to just thank all of our sponsors again. Please interact with them. Visit the photo booth by the elevators, and you can take some photos there. We'll start the afternoon session just a little bit later than what's on your agenda. So we'll start at 12:45 instead of 12:30. So enjoy your lunch, and we'll see you back here in a little bit.